He also asked us to look at the drop-off of AI tools between research and the clinic. And we went on to discuss data access, not data sharing, and to see this as the importance of this for diversity of data, to develop better tools, better insights for validating tools. And we looked at all of the factors that were between the drop-off of from research to the patient, regulation, public debate, best practice and tangible solutions. It was a busy day, super amazing discussions.
Right, we heard a lot about that. And we had 12 bar cams that were really popular. We heard from participants throughout the conference how great the format was and how deep you got into the topics like HIPAA and GDPR, like large language models, interoperability, or the topics that you brought up here. And we know that there are already projects and partnerships coming from there. So that's a really great message. We want to continue enhancing transatlantic data exchange and cooperation by bringing you together again for a last workshop about data against cancer at 10. And we will remind you to leave for this then at 10 o'clock.
We definitely will. We don't want you to leave yet, because before that, here on the main stage, we're going to continue our program. We have 2 high-level keynotes to kick us off. We have panels on the transatlantic access to health data and the transfer of research into practice, this topic that's been guiding us throughout. And of course, the last panel discussion is attended by the Federal Minister, Minister Karl Lauterbach, who'll close the conference for us at 3:30. So we really look forward to having you with us today.
But we're also going to start the day with a really special guest from the US. He's Senior Global Health Advisor at the National Institutes of Health and Associate Director for Planning and Budget at the White House Office of National Drug Control Policy. Please welcome on screen Robert Ice. Hello, Robert.
Good afternoon. How are you? It's a privilege to be here, and I'm so sorry I'm not able to join the conference because of obligations in Washington, D.C., but I hope that some of the perspectives that I'll provide over the next 15 minutes may be beneficial to the conference. I'm going to focus on the effects and implications of GDPR on transatlantic cooperation in biomedical research, which I know the conference has covered to some extent yesterday. I'm very pleased that NIH leadership is represented in this meeting. Susan Gregorek, the Associate Director for Data Science, who will be on the succeeding panel to talk about data transfers.
That's great.
A brief note of context. The NIH, as many of you may know, has statutory authority to provide foreign grants and contracts to foreign institutions. So if one did a snapshot audit of the NIH grants portfolio presently, it would be 4,000 projects, discrete projects in the European Union. A quarter, 1/3, 1,000 of those are situated in Germany. Largely, these are collaborative awards with US domestic institutions. So the impact and implications of the GDPR really are for the National Institutes of Health, which is the biomedical research arm of the US federal government. They really are substantive. They really do demonstrate what has been coined by a Columbia professor as the Brussels effect, the oversized impact in the capacity of European governing institutions to really frame standards and rules which other organizations and entities comply with as a cost of doing business in the European market. 20 years ago, this year, the United States layered privacy law onto some 2 decades of human subjects protection, known as the common rule. And we still experience some growing pains from that. But as you know, GDPR is an omnibus regulation. So the general principles that apply to commercial trade also apply to biomedical research. And that has been the challenge for US investigators in navigating GDPR, that its default lens, if you will, is the relationship between the private sector and the consumer, and that's typified by how extraterritorial reach is defined. It's defined by the provision of goods and services in the European Union. I'll speak very, very briefly about the basics of GDPR. Most of you know this. It was framed to provide data privacy as a private right and harmonize data privacy regimens throughout Europe. The scope of data that is covered by GDPR is far more extensive than the Health Insurance Portability Act in the US. It includes synonymized or coded data. And as you know, under HIPAA, if a certain number of enumerated descriptors are stripped out, it falls outside the regulatory scope. There is arguably no anonymization safe harbor within GDPR, simply because with progress in inferential analytics, big data, imputation techniques, even genomics data is arguably identifiable. So it's been very, very difficult to find that very narrow space that falls out of GDPR and could be characterized as fully anonymized. The effects for NIH are considerable because, as you know, one needs a legal basis for the transfer of data outside the EEA. Presently, European institutions cited in the European Union are not concluding international agreements or administrative arrangements under Article 46. Certification and codes of conduct are not viable for US public agencies. And the mainstay, standard contractual clauses, the United States is, at least the public sector, organizations like NIH, the National Science Foundation, the Department of Defense, and others, are unable to sign on to because they present statutory conflicts, incurring liabilities, for example, or they conflict with principles of sovereignty, such as governing rules, the jurisdiction of the European courts. The NIH is not in, and finally, the derogations in Article 49, in our view, are so narrowly defined that they've become really an impractical proposition as a durable means for transfer. The effects are that since enactment of GDPR in 2018, the US is, the NIH has only been able to complete 2 data use agreements with European institutions, one in fact in Germany, the Cancer Research Center in Heidelberg. 49 of COVID protocols in Europe looking at monoclonal antibodies as a therapeutic entity could not be enrolled, largely because of GDPR prohibitions. And I would also note that the data, this isn't a data issue per se, and the NIH has for several years, for a number of years, collaborated with Europe in a bone marrow transplantation network. And in a number of sites, we are unable to secure data and biosamples from matched donors because of the sanctions and restrictions imposed by the GDPR. And that's affected in experimental protocols the ability to provide hematopoietic stem cell transplants to patients with otherwise intractable cancer. The importance of transatlantic collaboration really cannot be overstated due to the fact that with advances given the diversity and complexity of molecular profiles and pathophysiologic phenotypes, it's more important than ever to recruit patient populations transatlantically to provide statistical strength to a study. And as I'm sure has been discussed, this is also key to fueling AI, which is going to require multi-dimensional, multi-sector data sets to have utility and applicability. Also, multinational studies help ensure that the outcomes of a vaccine or therapeutic trial are more globally applicable. There are some green shoots, and before noting that, this to us is an important issue in part because other countries, Chile, Peru, South Africa, China, have used GDPR as something of a legislative model and are either aligning with or adopting many of its provisions. So it's having that global effect that one didn't anticipate in 2018. The green shoots are as follows. We are in early discussion with the European Commission on what are the potential creative solutions that both carry forward GDPR's essential and important safeguards related to data privacy, but also enable U.S. public agencies to meet their statutory obligations. And we're discussing the potential of, for example, a blanket administrative arrangement that could be used practically as a docking mechanism where universities could sign on to this sort of broad agreement. Also, as many know, a year ago, President Biden and President von der Leyen signed the Transatlantic Data Privacy Framework as a means to address the concerns, largely over signals intelligence, that resulted in the invalidation of Privacy Shield for the second time. Its predecessor was Safe Harbor. The Department of Commerce expects the agreement to be enacted as early as late July. We're currently in late negotiations, and of course, the European Union member states needs to sign on to this provision. This will involve commercial transfers, the $1 trillion of commerce transatlantically every year. In this case, trade has trumped health in terms of where it stands on the queue of reforming data protection. However, there are some features of the transatlantic privacy framework that could be adapted potentially. For example, a review court to serve as a type of arbitration or dispute resolution mechanism. And this is important because one could argue that the most stubborn issue in resolving the data nexus of GDPR is the inability presently legislatively of the United States to provide data rights to European residents or judicial redress. I would characterize that as probably the most challenging of the legal thresholds that one would anticipate that the Commission and the European Data Protection Board would expect from us in developing a non-commercial arrangement. I'll conclude by noting that really an ethical imperative, and that is that patients who donate samples or data under a clinical trial or observational trial protocol do so in the main with a beneficent expectation, with the expectation that the outcome will be generalizable and help advance medical progress. I think the current understandable and I believe unintended data bottlenecks between the US and Europe related to the transfer of pseudonymized data presently fail to sort of adequately address the patient's interests in that respect. But I'll conclude by noting that with measured optimism, I'm hoping there could be either through closer interpretations of European Data Protection Board guidance, through potentially the development of a sector-specific adequacy decision related focused on health research, applicable to organizations in the United States that are covered by HIPAA or the common rule, our terminology for human data subjects protection legislation could be potentially explored, recognizing this is a long-term proposition. Adaptions to Article 46 safeguards, such as, for example, a bespoke standard contractual clause for biomedical research that does take into account statutory obligations of third nations, but also carries forward the important legal protections that have been provided by the GDPR. perhaps, although this is more of a half measure, more permissive interpretations of the Article 49 derogations, particularly explicit consent and matters of public interest, which presently are the interpretations and applications are so narrow, initial transfers, non-repetitive, that it's not really, hasn't proven it's proven only a one-off and not a scalable solution. So with that, and I know I provided a lot of information, but I would note in conclusion that the NIH is very willing to work with the Federal Ministry of Health and others in Europe in coming up with potential practical solutions to this issue. We've spent the last 5 years arguably on a problem statement. It would be gratifying to sort of progress to a statement of potential solutions which carry forward the enshrined privacy rights available both through the GDPR and through decades of privacy legislation in the United States. Thank you so much for this opportunity to address this audience, and I look forward potentially to further discussions. Thank you.
Thank you. Thank you very much, Robert. This was really enlightening in terms of regulations. You already gave ideas for scenarios, and I think our federal minister is on the same page. Maybe I can state that. Thank you so much.
It's a pleasure and a privilege.
Have a great day.
You too. Thank you.
And now, moving on in our programme, we would love to invite our next speaker, who has a very unique transnational perspective, has been instrumental to organising the conference, is the medical director at the Centre for Integrated Diagnostics at Massachusetts General and the Associate Professor of Pathology at Harvard Medical School, our very special speaker, Joe Lennertz.
Welcome.
Thank you very much. Is this a cool conference? I mean, to you. I needed to say this because with the team, and a big shout out to them, it was a vision and it came reality. So it's my pleasure to say a few words about the context and why I think this might start something that's a little bit bigger than, individual components that we are accomplishing here. So one statement by Andrew Weinberg is that scientists and science provide the means, and politicians and politics decide the ends. Now, maybe it will make sense in a moment why I'm using this quote to start off this very short keynote. Whenever you face certain really large, momentous challenges, it's good to look back in history and see how others have solved issues before. And one problem that we came across in the team when discussing this is the so-called la question sociale, the social question. In the 1800s, industrialization pushed people to the big cities where work was available through the engineering progress. And that created a very big divorce between the recognized and fully acknowledged value of social values that contrasted drastically with the misery associated with the economic growth. That posed a phenomenal so-called supranational question. And I think in large abstraction, and I will make 2 or 3 arguments why, I think right now data for health poses a similar supranational question. Let me explain briefly why. So over the next couple of decades after the social question, lots of enormous political and scientific social strides have moved us to a way where we can actually think supranationally, where we addressed some, definitely not all of our social challenges, but as you know, the beacon of our societies, the cities, were challenged. Society has recently faced something that exceeded its capacity. The pandemic, for example. If you think at sustainable development goals or the climate crisis, that's certainly not able to capture at a national level. It affects us all. Maybe the pandemic has pushed us out of the cities back into our homes, where we address supranational challenges within the four walls of our small, let's say, family environment. Now, when facing that and seeing what Robert Ice just illustrated as basically vectors pointing in seemingly different directions, there's GDPR with great intentions, but it somehow doesn't comply or jive with the way that the US is thinking. And then within the US, also induced by the pandemic, individual states diversified their individual legislation around data and consumer rights, which creates kind of a mosaic of rules and regulations that have to be brought back together. While on the other hand, in Europe, we have basically a bottom-up and a top-down problem. There are great ideas like the AI law, there's GDPR, there's very well-intended legislation that now has to be broken down to the individual state level. Every member nationality would try to adopt that law and has to break it down not only at the federal or state level, but make it workable in hospital settings that might or may not face, enormous financial challenges. So what I outlined right now is what I believe is the current biggest threat. That is a supranational question. It is not affecting one, it affects us all. And AI, our data, provide a very interesting means to start attacking some of these questions. But how? How can we do this? The second part is the magic, and that is how we can address this. And that is something that is referred to as pre-competitive space. And in large oversimplification, I want to point out a few things about that space for various reasons. First of all, it is a very abstract space. It is very hard to define. You can find numerous publications, you can ask ChatGPT. It is a fluid space that has no hard borders. But I try to outline a few of those borders just to illustrate how complex that space is. First of all, it is not a space that's taught in universities. No one explains to the students, to those who will soon replace us, what the pre-competitive space will look like in the future. In fact, we're all contributing to it, but we're not actively aware of it. We're talking about something where you collaborate without a direct commercial interest. It is truly a benevolent idea that you put forth and run it by other people to try to see where you're wrong. That is not a traditional approach in a commercial setting, but it is a very scientific approach. It is an environment where you throw out hypotheses, your ideas, and see how they resonate with colleagues from other disciplines. That is probably what was called in the 80s interdisciplinary research. But interdisciplinary research just stays within the research realm. That's just one fraction, just one layer of society. That is not sufficient to tackle supernatural questions. So we're talking large problems that need to be addressed before they're manifesting. Think of air traffic control. That is an approach that has to take many, many different stakeholders into account before you have an accident, and then you do a root cause analysis and you fix things that you may have been able to identify beforehand. You can go as far as the moon landing, where you need to plan something that has never been done before, and you need all kinds of input. So there are some areas, some disciplines that embrace this approach fully. Now, if you address broad issues that really move a field forward, you need to collaborate, and you need to collaborate with the people you wouldn't normally collaborate with. If you're interested in data sharing, you have to collaborate with those who are otherwise considered your most vicious enemies, because you need to convince them that your approach is better. That is why this group that we brought together is of such broad stakeholder content, meaning we invited everyone, including the press. Some people say, let's not invite the press because that might have negative consequences. That is wrong. In the pre-competitive space, you want all stakeholders come together. You want patient advocacy there. You want the most vicious patient advocates on the same table. Yes, that might get wild, and I noted the noise level out in the beautiful space here, and I think you participated in that, and that is absolutely intentional. So in other words, the pre-competitive space, the second part that I just mentioned, is what you witnessed. You're witnessing it right now. Now the practical part. What are we actually doing? What can we do? So there's this beautiful term that's called regulatory science. When I heard that first, I thought that makes absolutely no sense. How can there be science about something that is created by us? That's like somehow contradictory because we made it so we could change it. Now the term means something slightly different. So again, hundreds of definitions, largely oversimplified. There's translational science or translational medicine. In translational medicine, we translate something to address a health need. In regulatory science, we address a regulatory need. And oh God, do we have need for better regulation. So if you apply, and now we're getting very complicated, regulatory science in a pre-competitive space, we're mixing two meta levels on top of one another, and that may require 2 more sentences. So you apply the scientific method to develop and refine regulation. That requires probably at least 1 good German beer and a good friend who you can talk about that idea. But if you create data, any data, I would go as far as saying they may have regulatory implications. Since this is not taught in medical school or in any graduate education, think about your papers. When have you written a discussion paragraph that says, our findings may have the following regulatory implications? That requires a different vantage point. So I'm using this stage now to share this very practical approach with you. You don't need to have politicians directly on your side. But when you communicate your scientific findings, I urge you to think about what your regulatory implications are and include that in your paper. The reviewers will like it. Sometimes it makes the story even stronger than it already is. The second part is, let's put this regulatory science in perspective. If you break it down where regulation affects it, there's the preclinical part, the clinical part of a study, the post-market introductory phase, and the health policy space. Those are the classic 4 domains in regulatory science. What you're witnessing right here is the first conference that brought regulatory science into pre-competitive space, which is uncharted, no territory has been mapped, and we have the chance to address evidence-based decision-making by the lawmaker by providing that input directly to them. You had the chance here. You were talking to politicians and the various stakeholders, and that chance, if you don't take it, in my opinion, is a missed opportunity. So in summary, to address supranational, large-scale, momentous problems, you can apply regulatory science in the pre-competitive space. And I hope that my brief illustration has illustrated what this is, and we call that data for health. Thank you very much.
Thank you so much.
Thank you.
Thank you so much for those remarks, because you've taken us up so many levels there. So meta on meta on meta, but also with some really practical instructions for us to leave the room and do. Thank you so much. So I'd love to invite all of those who are going to attend the workshop in the Verpackungshalle to exit this way, and we'll give you a moment to do that. And at the same time, I'm going to invite the first panel onto the stage. So we've got Birgit Bauer, Susan Gregoric, Chikwe Ihigwazu, Lawrence Lessig, and Eva Winkler. So please welcome to the stage panel, and thank you to those who are attending the workshop. We really look forward to hearing your findings later on.
Thank you.
Brilliant panel, welcome. Thank you so much. So after a morning of keynotes, we're going to get down to some discussion. We're going to run the panel as we did yesterday, where I'm going to invite everybody to give their introduction and opening statements. We'll have some questions to go through. Indicate to me if you want to jump in after each other so we can keep the conversation going. And also we'll have Alexa to get some questions from the audience with a roving mic. So panel, thank you so much for being here today. It's absolutely brilliant. So you're sitting in a slightly different order to that I was expecting, but Susan, let's start with you, your introduction and opening comments.
Hi, so nice to be here today. Thank you so much for the invitation. It's good to connect with old friends and to meet new friends. So I'm really having a wonderful time, and the meeting has been fantastic. I'm Susan Gregorick. I'm the Associate Director for Data Science at the National Institutes of Health. You've just heard from my colleague, Dr. Bob Eisey. We're delighted to be here today. My role at NIH is to help transition our 27 institutes, centers, and offices to empower our data access, to look at data use. Fair data is a big point in our community, as well as care data, and also really think about ways in which we can work together for data interoperability. And so today I want to bring up 3 points. The first one I don't think I'm going to have to convince you very hard of, and that is that data for health is actually a really important concept when we're thinking about research and translation of research into medical applications. The second one may be a little bit harder to convince you of, and that is that data is not static, it's time dependent. We look at our data over the lifetime of individuals, but data is not only time and trajectory related, it's also related to where we are in our environments at the time that we're looking at ourselves. It's very contextual. So I'm going to talk a little bit about something that I haven't heard too much today and yesterday, social determinants and environmental determinants of health. That's really important for the US, and I'll give you a number of case studies so you can sort of hear where we're thinking. And then the third thing I'm going to tell you about, and hopefully we'll bring up, that might have a lot more discussion, is that, at least in the US, we're a very heterogeneous community of data science. It's very rich, a lot of innovative ideas, but there's no one uber structure of data. There's just a lot of different data resources, data infrastructures, data platforms. And our goal is to look at interoperability and federation across this distributed set of data and ways in which we can really aggregate and provide access to that data for researchers. So those are my 3 points, and I'm really looking forward to the discussion.
Susan, thank you so much. Birgit.
Yeah, hello, and thank you for the invitation to make this panel today. My name is Birgit Bauer. I'm the project coordinator from DataSafe's Lives Germany. I have 3 points, and I wanted, to be honest, I wanted to start to imagine how it could look like if it would be perfect, and we all know how it would look like. So I could share my health data and so on. I'm coming from a patient perspective today. At first, we need data. As a patient myself, I'm living with multiple sclerosis. I know the importance of data and how they can help patients and also their carers, also HCPs. It's so needed. We can learn more about diseases, and therefore we have to share health data across the countries, not just in Europe, also worldwide, I would say. So at the moment, I'm working with the One Health principle from the WHO. So for me, it would be important to do that in a worldwide framework. But, and this is the status, and I'm coming now with some insights, we need more health literacy. Or let me say it, we need more digital data and health literacy in citizens and patients. There are so many big gaps outside, and we have to, and we heard that yesterday already, we have to educate, we have to communicate, and we have to inform, and we have to reach the people, no matter where they are. Not just, and I love the Berlin bubble, but in the Berlin bubble, it happens so much. But it's just a Berlin bubble, but the world is a little bit bigger, I would say. So we need more education, we need more information outside, and we need those programs. They need to be easy to access, they need to be understandable, and they need also to invite people, and this is another important point for us, to be involved. Hashtag patient engagement. This is important. We heard that in the keynote before, and I was so, okay, should I give a round of applause for that? Because it was so positive to hear from me, to say, okay, guys, this is the right pathway. We have to involve patients and citizens also in the decision and the development processes, because last but not least, and this is not surprise, we pay for that. With all our taxes and insurance fees, we pay for that healthcare system. And we have to make it much more easier. At the moment, I see that as one of the biggest issues we have worldwide. Also, we need the data coming up from that for prevention. If we don't do prevention, how can we do pandemic plans? I never would want to experience that, what we have experienced during the last year. It was a mess also for people living with diseases, not just for those living with multiple sclerosis. And I think if you ask cancer patients or others, you will see the needs. So therefore, I think it's time to stop discussing. It's time to start creating something valuable worldwide, to be able to share health data, and also to make clear that people understand the value and the benefits of health data sharing. Because those people have to come in this train. They have to come on board of the digital track. If they don't do it, others will take away their role. And then we have to ask ourselves, maybe we need another job? I don't know. Thank you.
Okay, thank you so much. So the patient is waiting for us. Chikwe.
Thanks a lot, and thanks for this very important conversation we're having in Berlin over the last 2 days. So I lead, my name is Chikwe Ihekwazo. I lead the new WHO Hub for Pandemic and Epidemic Intelligence here in Berlin. We're less than 2 years old. Let me start by what I think was a shared experience from a population perspective. I mean, in Germany and literally in every other country around the world, we watched our ministers of health, our chancellor, our president, try to explain to the population through the pandemic what was going on, what was driving spread, who it was impacting, what the outcomes will be, when shall we lock down, when shall we open up. Very difficult conversations. And we saw how they struggled. And this was a shared experience. In almost every other country, the same set of people were struggling with the same set of issues, often standing or sitting next to the head of the National Public Health Agency. In Germany was the leader of RKI. And they struggled because there wasn't the seamless access to the data that they needed to explain to the population what was going on and what they were able to do about it. And we have to imagine a future, if that we were ever in that type of situation again, that we would have more easily available, accessible access to those data points and be better prepared to use it to explain to people at least, if not to define policy and the response. And really that's the reason for the existence of the hub here in Berlin, to learn. There are many lessons to be learned from the pandemic, but that particular set of lessons is what we're working on every single day at the moment. And we're working really around 3 goals: to connect better, to innovate together, and to strengthen existing systems. So when people hear about the hub, they often imagine a big data collection hub with supercomputers where all the questions you have might be answered for the world. But maybe that will come in the future. The very beginning is actually to connect. So a lot of the data we need is actually collected, but just in disparate data sets around the world. How do we connect those data points so that we can make decisions? The second is around innovation. Innovation happens all the time now, and it's a good thing. The challenge is if every Gesundheitsamt, for instance, in Germany, were to innovate and develop a different system, then we will not be able to connect the data that they have. And we will end up with maps that are different graphs and all sorts of differences. So we have to think about the next level after innovation. How do we collate and make sure that the different pieces coming out from everywhere around the world make sense for the world? And finally, is to strengthen that in every country, there are people that have done this already, that are doing this every day. So we want to build on what we're doing. My very last point, I love the point Joe made in the beginning about collaboration. And I just thought to bring this, I dug it out of my bag just as he made those comments. It says defining collaborative surveillance, because as much as we want to improve our ability to collect and analyze data, the sweet point is on the collaborative aspects, and we've not invested enough effort on that bit.
Thank you so much. Great points. And I love how your theme of collaboration also fits so strongly with the theme of the conference, which is we have lots of expertise amongst us, but we have to bring it together. We have to collaborate. Eva, can I bring you in?
Yeah, thank you. Thank you for this great conference. I'm Eva Winkler. I have two hats on. I'm one of the directors of the National Center of Tumor Diseases and practicing oncologist in Heidelberg, one of those collaboration partners that were mentioned. And my research is on ethical issues with a large focus on data ethics. So we survey patients, we work very closely together with the stakeholders and try to bring these perspectives into national and national collaborations like the German Genome Archive, and at the European level, the 1+million genomes, all about genomes, so the most sensible data, and then also the Global Alliance for Genomics and Health. And what I learned in these different fields are at least 3 points. I think patients really are willing and want their data to be shared. I think citizens already, but still, if you had an experience of having a disease, you want science to learn and to benefit yourself, but there's also a very altruistic motivation to make your data available. And now the big if comes, if there's a trustworthy governance in place. So patients don't care in the nitty-gritty details of every single do I put my data in this study or in this study, but to be safe that first there is really research done with the data and that there is an outcome that benefits patients. So I think we really have to focus on the trust architecture. And there it is transparency first, and that's 3 criteria. I think it's transparency of the data use, it's data protection standards, but a balanced one, risk versus benefits, and also that patients participate or are somehow represented in the governance structure. So that was, I think, the first what I learned over our surveys. The second is we made in Germany, for German perspective, a big step forward from specific consent to broad consent. So we are now roll out on broad consent over all university hospitals here in Germany with the affiliated hospitals for one-time general consent. And we know from our surveys with patients that they favor this. That's the highest approval rate. We surveyed over the cancer registry 840 patients, and broad consent was the most favored model, but closely followed by an opt-out model. And we learn now that even if you only take 7 minutes per person to explain a broad consent model, and if you scale that up to thousands of patients every year in every hospital, in every doctor's office, that we don't just have the staff and the people to do that in terms of time and knowledge. So an opt-out model where it's a standard that your data are used for secondary research, and you have a low threshold of opt-out would be the thing we need. Prerequisite would be that there's a large information education campaign that every citizen knows that data, unless you don't object, are used for research. And the third is the transatlantic. I think there, a transatlantic data exchange for research. I think there we have really the largest challenge. Because we know that's beneficial and it already results in better patient care. International Cancer Genome Consortium has brought about so many new therapies, but we need good data protection standards that are mutually agreed. And I was happy to hear that this executive office of President Biden put the way forward to get up a new data sheet. And here patients also say, well, we are happy for cross-border data sharing, but that should be about the same standard. And I think also servers of commercial companies and other jurisdictions are also an issue we need to address. So these are the 3 points for discussion.
Thank you so much. There's so much to get into there. Right, Lawrence, finally, please introduce yourself and give your opening comments.
Right, so thank you very much. My name is Lawrence Lessig. I'm a professor at Harvard Law School. In Ava's category, I'm wearing no hats because I'm coming to this from the outside and I want to cause trouble in the most effective and concise way possible. So I've written something. I apologize if you allow me to read it. There's a saying, I think, but if there's not, there should be. It would go something like this: we should not do efficiently what we should not do at all. It's that idea that I'd like to add to this conversation, playing the role of skunk at the garden party, because it is my view that privacy law made a fundamental mistake at its start, at least at the start of the digital era. At the core of that regulation is a concept of individual consent. That choice, the choice of that regulatory architecture, was a fundamental mistake. And the consequence of that mistake is, literally, the deaths of unaccountable individuals who would be saved by more effective and informed medical treatment. Let me state the point as starkly as I can. We are sacrificing real human lives to benefit a vague and ultimately meaningless idea of individual consent. That claim, of course, is the claim utilitarians generally make when arguing against individual rights that conflict with the general good, but I don't say this as a utilitarian. Instead, I mean that the good this choice architecture is said to protect is not even recognized by the individuals who are said to benefit from it. I hazard that there is not a single European not employed by the EU Data Protection Board who is happy with clicking through cookies policies to view the internet. And I doubt there is 1% of medical patients who are glad to give repeated consent to the use of their own data in their own treatment multiple times during the progress of that treatment. We, or more precisely Europe, have erected a massive machinery to secure benefits no one really wants and which forces serious and brilliant souls like those on this panel to work through 1 billion hacks to achieve the Enlightenment's objective for medical research. So what would the alternative to this architecture be? Well, I think I have about 50 seconds left, so I don't have time to articulate that fully, but here's the core idea. We should not be regulating data. We should be regulating uses. And we should not be regulating uses based upon individual consent. We should be determining permissible and impermissible uses through a kind of Rawlsian veil of ignorance. Through citizen assembly-like structures, citizens should identify uses that should never be permitted and uses that should always be permitted, and for the presumptively narrow band between a machinery of consent might well be used. I realize that's too little to frame a real conversation. I realize this panel on the importance of the use of health data and transatlantic access to health data is not really the context for that conversation, but having flung myself here from Boston with the aid of Lufthansa to come here, I hope you will forgive me for saying something that I hope someday is completely obvious, that this Rube Goldberg machine of data protection is not just unnecessary, it's positively harmful. And because is it thousands, is it millions, who ultimately lose because we can't share data easily, will never be invited to a conference like this, let me at least utter this on their behalf. Autonomy is a privilege of the living, and fake autonomy is the curse that leads too many to leave us, the living. Thank you very much.
Lawrence, thank you so much. So panel, I'm going to suggest that we pick up on this point because I can see many of you kind of nodding, thinking about responding. So who would like to come in on this?
Okay, I start.
Yeah, I think you convinced the panel, right?
So from my perspective, I agree. I think data protection is important. But we heard yesterday, and this is what I'm preaching a long time now, we have all the things in place, but we should not over-secure data because we need them. So without data, no learnings. How can we make healthcare better? How can we take care for people who are suffering every single day from a chronic disease? This is not fair. And therefore we need that. And so honestly, this is one of my trigger points, to be honest. But we are discussing that so much, especially in Germany. And to be honest, I can't hear it anymore because we have the things in place. We can do it. But at the moment, and this was also said very often, and maybe it's a cliche, I don't know, but at the end, do we protect data or do we protect citizens? This is the question. Is data more worth than human? I don't think so. But this is the point. And I think we have to start to, as I said, not convince, but to inform people how to share data and what it means. Because what I see from Data Saves Lives, people don't know it. They are not aware about those benefits. And I think we have to bring that in good stories out to say, okay, hey, there is this value, use it.
Eva?
Yeah, I think I was always halfway where Lawrence is heading. I think this is maybe a long-term perspective. And I would say, like I suggested, this standard or default use of data with an opt-out version would prevent that everybody is first, because there are also patients that say, well, we are, for example, the hereditary breast cancer, precancerous patients, we are afraid to be discriminated against getting a long-term appointment when having a genetic condition. And so it would be good to have an intermediate stage where those who are really reluctant and have good reasons to not have their data out for research with not zero, but some maybe risk of third parties accessing it to opt out and then get used to that, because I agree many patients are not interested to say, I want to feed my data only in this study and that. It's just more a general decision whether I want to kind of donate my data or not.
That's a great point. And perhaps, Chikwe, I could bring you in here because you also described the three kind of principles of the formation of the hub, almost like bringing together what we currently have. So I guess my question from this is, what can we do with the structures that we currently have? How far can we go? And would you also look towards these next steps the panel have outlined?
No, I completely agree. And one thing you said at the beginning was, at least in the digital era. So I think some of these things are just the lag between the regulations and the intent that we put in place 50, 100 years ago, which may have been justified at the time. But right now, the truth is we have technology, we have so many things that will prevent a lot of the things that we are afraid of, even if they were to be real risks. Let's assume they're real. We have so many ways to mitigate against them. And so many other industries with less at stake, I would argue, are doing this every day, whether it's financial services, it's air traffic control was mentioned the other day, a few minutes ago. So there are many other sectors that are already doing this as part of routine practice every minute. Somehow in the health sector, we haven't been able to get there, but the energy coming from this room is the same happening in many other conversations around the world on this particular issue, that we have now. There's a fairly broader understanding of the need. The technology is possible. At the global stage, interesting negotiations are happening right now on the new pandemic treaty. All of these are part of it to enable us share what we need to survive. And it's very important to understand how high the stakes are.
That's a great perspective. And can I just push you to say, what is possible now? Like, what are you able to do through the hub with what you currently have? You know, and what are you working on to change this?
So, you know, the conversations that are going on an individual patient level are very similar to the conversations going on an inter-country basis. So there's a lot of preciousness around sovereign data, our data in our country. But the threats the public health threats that face us, we cannot think about ourselves in 198 country blocks of data, right? We need to pull them together. So the intensity of these conversations are the same things happening. The opportunities that we have are, you know, on the technology side, a lot of federated data analytical opportunities in terms of not even needing access to the individual data points. We've talked about AI a fair bit. It will produce incredible opportunities. But for that to happen, the plumbing has to work. So the pipelines have to lead us to a data collection that we can then interrogate with the new tools that we're developing. So that's how the improvement at the patient level is so very important for the work we do at the global level.
Thank you so much. Susan?
Yeah, absolutely. What a great conversation, by the way, and not an easy one either. And I agree that in the US, at least, consent and privacy protections are there to protect individuals, especially minority and at-risk individuals. So we do have those considerations. But as Brigitte said, we have the technology. There's a lot of apps that you can consent and opt out for. These technologies are there. In the US, we're working to bring ways to enhance zero trust. So zero trust in data access, meaning that your authentication and authorization is checked on a timely fashion and continuously rechecked. You have an architecture that is at a very high standard. So we do adopt NIST 800-153 for our data architectures. Those are very high standards of protection. And we're working to bring in international researchers to our data infrastructures through things like ID.me. And so we have ways to bring you into our systems. They are very high and secure at FISMA Moderate and FISMA High. The data protections are there. There are technologies to let participants opt out and opt out in various ways for various data sharing. For example, I only want my data shared for cancer research rather than general research use. These technologies can be implemented today across our systems. And so I don't think we need to be afraid of them, but we do need to embrace them. And we're certainly willing to work with you on some of these technologies.
Thanks so much. That's a really clear kind of comment on what is currently in place and what you're looking forward to. I wondered if I could just pick up on something you said there, because you said, you know, we bring in international researchers to work on our data. And one of the themes of the conference is about this transatlantic access. So I wondered if I could just ask you, you know, what are the benefits of this kind of exchange that we're having here? Is it solely about data access, or is it what I think you were kind of alluding to, which is there's also a cultural exchange, or you know, looking externally across borders for other skills, or you know, what's the thinking behind that?
Yeah, absolutely. So having access and building cohorts that are very large across international boundaries are incredibly important, not just for cancer, although I can talk a lot about cancer, but we have a cancer expert, so maybe I don't need to. But there's also a lot of innovation that happens. So we work and partner with a number of activities, UK Biobank with all of us, for example, developing large cohort studies. But we also, and I know my colleague Ralph is going to be in the next session, we work with Elixir, and there's a lot of really good lessons learned in the way that Elixir is developing their hub and node and spoke model. You have an excellent amount of work here in Elixir in Germany. We've adopted a lot of standards from GA4GH, for example, for identity and access management. Elixir is doing the same thing. What does this mean? We can actually collaborate with researchers who are part of the Elixir enterprise at some point. we can exchange ideas and develop and build onto those. So our collaborations aren't just for data access and data capabilities for analytics, they're also for innovating new ideas and ways in which we can move forward. And I am absolutely certain we're going to see some really innovative AI coming from some of these partnerships pretty soon.
Maybe
Eva and then Lawrence.
Can tie in, because I think it's really amazing how many people are really working on infrastructure that are researchers in the first place, just to put up an infrastructure that enables then data sharing. So in the genomics field, it's on all levels. So we have that at the national level, having governance structures in place and sharing models for German Genome Archive that relates to the European level, the 1+ million genome initiative. But these are all people thinking about what would be good governance structures, what policies do we have in a return policy, or don't we need a return policy, what are accountability policies, and that are mirrored at the international level. And these are all the endeavors. So many people are trying to give good thought to put that up in a trustworthy way. But in the end, we need to use it. It needs to connect so that we don't spend all this time and thought and no data is exchanged at the end.
Yeah, I think that the cultural point is really critical. What I love when I come to Europe is the Europeans who tell me how crazy we Americans are in all sorts of dimensions, especially political. And that's wonderful because it helps us think a little bit more about our own perspective. I think we Americans need to observe the craziness in the European context around this particular issue. And I think your point is exactly right. The preciousness with which we approach this question, as if it's the sanctity of life itself that is at issue when we talk about sharing data, when sanctity of life is actually on the other side of this equation. If we could be sharing data much more extensively, my many friends with multiple sclerosis would have a much richer future to look forward to, as well as the many other diseases that have not been addressed because of the inability to test these data, the cures in an effective way. Here's one particular example. It always drives me crazy when people talk about the anonymization problem. Like, okay, we're going to take data, we're going to anonymize it. And then some geek comes along and says, yeah, but I can always figure a way to reverse engineer back. As if that stops the conversation. As if it's obvious then that, yes, we shouldn't be anonymizing and sharing data. Because, airplanes take off and they crash. That happens. But we don't say from that we shouldn't be taking off, shouldn't have airplanes taking off. I think the response to the anonymization point is to say, let's criminalize business models that are engaged in the process of reverse engineering back to particular individuals. In America, we'd say, let's do the death penalty. You can't utter that here, but at least corporate death penalty for any business that engages in the process of reverse engineering for the purpose of defeating intended anonymity. Now, that's not perfect. There will still be people who have been traced back against their wishes. But the point is, the net gain to society so overwhelms that cost that we need to begin talking about the craziness that exists in a world where this is the struggle we have to make science possible.
Thank you so much, Lawrence. And this speaks to your idea of regulating data use, not regulating data, correct?
Yes.
Vic, I can see you want to come in.
Yeah, so when we're talking about a cultural change, last week I was at the Patient Engagement Open Forum and I met 160 patient experts across the world. We had exactly the same theme on the table because we are discussing that. So the patient organizations, not just the designated ones, also the patient experts in this world, party fellows, for example, discussing that. And what we see is that we need this societal change, let me say it in that words, because health data sharing is also a question for a whole society. It's not a question for a specific patient group, for example. It's a question for us all, because every one of us can be a patient sometimes. It can happen, surprisingly, but it happens. So the thing is, when we started to talk about health data sharing, we need that cultural change, and we are in this I would say, a little bit crazy, but very innovative and inspire patient expert networks. We are working on that because we see the need. So, and we are here to help. So we are ready to do something and to engage also with governments, policymakers, and the other stakeholders. And I think also to bring in that cultural change to the societies means also to involve us, not just patients, by the way, also citizens. We have to be heard, and we need that seat on the table also to maybe to say, okay, this is my concern. I have a question there, and maybe I have a great idea to make things easier, also accessible for the people. And I guess this is what we need. This is this so-called societal change. But we have to think not just on patients, we have to think about citizens, because they can impact, it can be impacted, and it's for them too already. It's not just for one group, it's for all. It's this together thing, you know?
It's such a great point, and I loved as well how you said earlier, like ultimately we are here to serve the public. This isn't for ourselves, right? This is because we're doing it for a purpose, and we sometimes become disjointed by talking in this way. Yeah. So, Chikwe, did you want to come?
If just a small point on that, on the benefits outweighing whatever risks there are, that is being made on an individual level. But we also have to think about this on a global level, right? That investments, especially in the infectious disease space, that we make collectively through sharing and also responding to events in one corner of the world is not an altruistic effort for some country in that corner. It's in our own mutual best interest to share that information and to be able to respond to that collectively. So all the arguments that make sense on an individual level also make sense on a population level. And we as citizens also have to push for that, because it brings into question the role of industry, patents, all the complex conversations that happen globally. We have to have them and say, listen, we live, unfortunately or fortunately, in this world together. So where do we share enough to protect ourselves vis-a-vis what is necessary to protect the industries and the economy and the societies we live in? Not easy, but the pandemic has shown that this is not a conversation we can neglect anymore.
Such a great point. I just wanted to, Susan, change tack very slightly before we go to the Q&A with the audience, because you mentioned in your opening remarks the social and environmental determinants of data, and that's something we haven't picked up much in the conference. So I wondered if I could ask you to expand and give the audience a kind of heads up. We're going to be coming to you in a couple of minutes with your questions, so be ready.
Absolutely, and I want to do this by talking about a particular platform and a particular use case. And since you talked about health literacy, I think I'm going to pull one out from the All of Us program. You probably or may not have heard of our All of Us program. It's an ambitious program to provide a data resource for researchers and others, internationally, by the way, to understand the health and healthy outcomes. We have over 400,000 US participants. These are all citizens. They're healthy, they're not healthy. We're all in some stage of our health trajectory. They participate by providing their health encounter data. That's usually your EHR data and related data. They also provide their genomics data. We have a number of surveys, including a COVID survey. They provided their input into those through surveys. Those are structured questions and responses. And they provide their Fitbit or wearable data to us. And they provide their history, their family history. So this is a really rich data set. It's incredibly diverse. It's about 40 to 45% diverse in terms of African Americans, Hispanic serving populations, and others. And so this is really a wonderful resource. So researchers are using this all the time. We have about 272 publications thus far. And just this past month, so this is a June publication, researchers were interested in understanding if they could develop a clinical predictive model for the relationship between SSRIs and bleeding. So this is apparently a real problem. I'm not a doctor, I'm a data scientist. You'll get that sense if you talk to me about biology. So they really want to develop this AI model on this. And so they're using the All of Us cohort, looking through the entire cohort, finding the populations through EHRs of those that can actually fit that description, and developing models. And guess what they find? There's a few predictors that really will help doctors understand, and this is a clinical decision support, preliminary study, whether or not somebody who's going to get an SSRI may actually be prone to active bleeding. Health literacy. They're collecting that through survey data. So that's sort of a social determinants of health. If you're not really reading that long amount of information that you get with your SSRI and your warfarin, you probably are going to be at risk. Also, other things that are prognosis for the relationship between SSRI and bleeding, social determinants of health, your social economic standing. So if you happen to be in a lower moderate income, your propensity for bleeding is a little bit higher. And so these are predictive outcomes that we can use. Sometimes I give another analogy in asthma, because that's a real obvious one. Your asthma probability is very high if you happen to live in a very dense population with bad air quality. And we happen to experience this on the east coast of the United States with the wildfires from Canada coming down. We got a code purple. I had no idea that the codes went up to that color. And so people, and especially African-American children, who are very prone to acute asthma, were on high alert. And so just having that social and environmental determinants of health. What is your housing situation? Do you have mold? What is your food status? Do you only have one meal a day, and is that meal provided at school? Are really critical when we're looking at health and health outcomes, especially when we're looking at long-term trajectories. And so is health literacy. So I just want to sort of put a plug in there when you're thinking about your data for health, that there's a lot of contributing factors that contribute to our health outcomes, and these are some of the important ones.
So important. So what I'm hearing you say is, not only can we see patterns of social determinants when we look at these big data studies, but also there's a critical role in creating the data sets that enables us to pick up these other social determinants.
Absolutely.
Okay. Let's go to our first question.
Yeah, Naomi, we have a few here. So
okay.
First one.
And then one on the front row, Alexa.
Stephen Gilbert, University of Medical School in Dresden, Professor of Medical Device Regulatory Science. I have a question about platforms and elephants in the room and what the role of GDPR is, and also the considerations of the European Health Data Space, the Digital Markets Act, and the Digital Services Act. And it's partially directed to Lawrence. What we're seeing really, we're talking as if we're talking about the access of data, which relates to a difficult and obstructive process under GDPR for one researcher's grant they applied for collaborative research in the past. What we're actually looking at in the future, Mark Andreessen said that the next $1 trillion valuation company is in health service delivery. The same companies are in the platformization of health. And this may be a good thing or a bad thing, but we need to acknowledge the elephant in the room. Google Health, Apple, who have later, are the same companies collecting the data, providing the services to individually, increasingly interacting with the health services. Ipsos Mori poll that you'll be aware of from Google Health, studying patient perspectives and data sharing within the NHS, published last week. There is a move to get access to the data for the use in generalized medical models, generalized AI, great paper by Eric Topol in Nature on this. The machine use of that data may be a good thing, maybe a bad thing. I'm talking about individual researchers. The domination of the pre-competitive research is now dominated absolutely by Google and by Microsoft. Maybe a good thing. All the best papers, all on archive, slowly making their way through to Nature, New England Journal of Medicine. Maybe a good thing, maybe a bad thing. The space, the pre-competitive space, can only be touched on by researchers. It is dominated by the big platforms, the big US platforms, the role of Palantir within the NHS and data. These are the elephants. There is a route where the participative patient access to data is some form of safeguard against, or at least a democratic vote of the patient, saying to what extent do I enable the cyclic care delivery, care ownership, care cycle, digitalization of the self, digitalization of the person, and the extent, with large language models, etc., of the direction we're going in. And the question is, am I wrong?
So I think you're right, but let's be clear about what you're right about. So yes, the space is being dominated by platforms. Platforms have commercial interests. The first question we should ask is whether the business model of the platform is consistent or inconsistent with the public good the platform is serving. And we have to build in safeguards to assure that to the extent the business model shifts, there's ways to escape. So for example, you mentioned research data. So long as the data or research papers are licensed in a free way, that at least allows a way to escape. And that's a critical part of the point. But there's a more fundamental question that I think we have to push on. And that is, when these platforms take ownership or take a dominance in these data, there is an ultimate regulator. And the question is who that should be. You suggest that the individual's choice about privacy somehow is that effective regulator. I just don't agree that that is an effective regulator. I think the individual at the point of deciding how she will be cared for in a cancer treatment is not the person who should be is not in a position to be making that judgment effectively. That's why I say the Rawlsian veil of ignorance is the device we should be deploying to ask how this judgment should be made. And here in Europe, you have been experimenting with infrastructure that could make those decisions quite effectively. The experiments here in Berlin and in Paris and in Belgium and in Ireland around citizen assemblies are experiments in democratic deliberation that can be freed of the commercial interests that might be driving underlying infrastructure, that could begin to make judgments that are representative in a much more effective way than either legislators or the individual making a choice in a privacy form. So I agree, democratic constraints are essential, but I reject the idea that individuals making a choice on a form when they go in for healthcare are an effective proxy for that democratic choice.
Thank you very much for the. Can I have the microphone? Sorry. Thank you very much for the question. I kindly ask all the audience and the panelists to shorten their questions and their answers because we have a few here. So,
okay. Thanks, Alexa.
Hello, everyone. Jennifer Bay from the American College of Cardiology. Lawrence, you surfaced a really important question, and many of the panelists responded to it. But I find myself wondering, after our time together so far, if we have neglected a really important aspect of the question about consent, which is, as opposed to thinking about it as an individual burden, is there more benefit to be derived from contemplating protection from harm and recourse if harm occurs if one's data is exposed? Thank you.
Succinctly, panel.
Yes.
Oh, let's, Eva. So yes, and?
In fact, there are good ideas about how that harm could be recorded and how harm mitigation strategies could look like. So if you have a pool of data that you use, you should make sure that no inferences that result in harm are disproportionately distributed and how that could be addressed also, again, a governance issue.
Thank you so much.
Benny Levinson, American College of Cardiology, European Chair. I especially want to thank Lawrence for opening the window into our bubble. Maybe somebody could open the window here to the hall. I think if it comes to data protection, we need to readjust our wording, readjust maybe our contents. I think we wait too much on the individual consent. And I want to take you back to the future. We're talking about the future use of data. Do you all still remember the pandemic? There was a country with a completely digitalized health system who provided all their data to Pfizer and BioNTech. And this enabled the companies to go on with developing the vaccine. It was the Israeli system. And I just talked yesterday to one of my best friends who used to be the anchor of German television in Tel Aviv for 10 years. And I asked him, what did people say about that? And here we're coming back to culture. It's a cultural question. It's a social policy question. And he said, nobody really cared. because they're used to that. So I think changing the wording, changing the contents, and then we might be faster into the future than we think now.
Birgit? Yeah.
I couldn't agree more, and I think we need more from the good stories outside. Because we had lots of patients suffering from the pandemic also. Can I be vaccinated or not because of my therapy? There were some therapies out and it didn't work with the vaccination. There were no antibodies. The data came from Israel, yes. And patients were, I would say, a little bit more calmed down because as they heard, okay, you can be vaccinated, that's good. For many people, this was one of the good messages in that whole bad time. And I would say we need more of a better wording. I agree. And we need more stories. We need more of these success stories outside to make people understand the importance and why we do it.
Chico?
Yeah, and maybe to add to that excellent point of the positive, there's also the story of the negative. When South Africa shared their data on the emergence of new variants of COVID, how did we respond? How did our governments respond? And have we as citizens asked our governments what were the benefits of shutting down these countries against the best advice of those that should know? So against the advice of the World Health Organization and the regional health bodies saying, listen, there's no value in trying to do this. They felt, I think, to be responding to pressure from citizens, which I'm not sure is the case. So I think we really need to reflect on both the positive and the negative outcomes of these stories that happened through the pandemic.
Thank you so much.
Yeah, hi, my name is Florian Schneider from Roche, and as a data protection officer, I 99% agree what has been said on the panel. I joined the garden party with a skunk, and a little bit I have to say that the smell doesn't come from Lawrence, obviously, but also doesn't come from GDPR. GDPR allows for data use without consent. It's clearly stated, it's not like a better legal basis to ask for consent. It's one of the legal bases there are, and there is an exemption to do research. And there is national law that also provides for this legal basis to do research. Regarding your anonymization aspect, of course, GDPR asks for anonymization if that's possible. If it's not possible, it's still okay to use the data. So there are tools already in place. I think it's sometimes in our heads, sometimes like in national laws, which can be interpreted too narrowly. The Ministry of Health is going down into this direction of opt-out, so another legal basis to consent. I think that's good. We have to be clear, we have to be transparent, we have to build trust, we have to explain, but the tools are there. So it's not GDPR, also not for the cookie banners at the end, that's a different discussion, but the tools are here. Let's focus on purposes, not on persons. Let's focus on what we want to achieve and not exactly legal discussions whether the consent is really needed. If we do it differently, if we do it transparent, I think we have all the tools. If then the national legislators come together and share this vision, I think we can achieve a lot also in the existing EU framework. Thank you.
So I joined the skunk, but I want to just say in response, I didn't use the word GDPR. I used the word choice architecture, which I think is presumed across a wide range of regulatory structures. And what I was saying is we ought to be open about thinking about an alternative architecture for regulation that wasn't grounded in individual choice with exceptions, but instead started with a framework that asks the more fundamental policy question and then built choice on top.
Eva, thank you. Succinctly, because we've...
Very short, because as a data protection officer, you already made, obviously, this culture change. I think there must be many more in the countries that use this kind of interpretation of the tools that we have. And what we experience every day is a very strict and protection-focused interpretation, because a data protection officer gets kind of in problem when there is data leakage, but does not get in problem if data are not used. So I think that's a good way forward, but needs culture change.
A great point about misaligned incentives. Okay, thank you.
Yeah. Rolf Dietlef Trede, I'm a member of the WHO Council that oversees the WHO classifications. And I have a question for Chikwe. You pointed us to public health needs, which is step 4 of regulatory science, and you called for standardization of reporting. I'm sure you're aware that in 2019, WHO developed this tool, but it was developed by people who are used to very slow timelines. So it was voted in May 2019, before the pandemic. And there were analyses in the US and Germany that said we need at least 5 years to even consider this. And then the deadline was set January 2022 to start reporting causes of death. And then you have 5 years to change things. And what WHO decided is to abandon the book, and it's a database. And I'm wondering whether you should be a little bit more impatient and leverage the data for health approach, which needs things to speed up. And also your use case is pandemic preparedness. So do you think there's a chance that WHO can promote its own tools and speed up things?
So I think, thank you very much for that. I mean, you've hit at one of the foundational challenges of a member state organization of 194 countries with different levels of capacity, speed, agility, expertise, and finding a path that is appropriate for all these members because they all have a stake in it. So I do agree with you that sometimes we should use our levers a little bit more aggressively, but we have to carry everyone along on the journey. And so sometimes things are a little bit slower than some of us might wish for it to happen. So I think it's a well-made point, and I think also the pandemic, the incredible changes in terms of what is possible these days with technology will change those conversations. So I'll take that point back and take it to our colleagues and see how we can drive the agenda. But consensus building is not easy. And unfortunately, it's a big part of our work is not actually at the cutting edge of what is possible. It's at how to bring everyone along on the journey that we need to go collectively.
Thank you so much, Chikwe. I'm sorry to cut across you. We've got one question here, one in the front row, and then we'll...
2 other more, but we see.
We'll see, okay. Hi, I'm Kiara Lukomsky. I'm a representative of young people in healthcare. And we talked a lot about the system problems, and everything seems so slow. And to be honest, I feel kind of helpless sitting here and we're all talking. What would anyone on the panel, advise young people especially to do? Do you advise us to go to other countries, look how it's there, and come back?
What can young people do? I'm afraid to say, look at all of us here.
I think maybe what all other best ages can do as well. I think maybe not only a question for young people, but
I think...
Okay. Chikwe and Birgit, both of you.
I would say come together with others, start the discussions, and also raise your voice, as from the patient expertise and from the patient advocacy do. And maybe come together with us patient experts and also go together with patient organizations also to see their perspectives. Because I think it's important to have those perspectives on your radar and know what the others think. Maybe this can help for a first basis, for example.
Chikwe?
Basically on the same line. Vote more, for instance. Come out and vote. Because it's by voting, by being politically active, by raising your voices, that our leaders represent you as well. We've seen many big decisions made globally that I don't think would have been made if young people actually had their votes.
One more line?
Yeah, so just to add that, I think together and common are the keywords here. Because we can't do it alone, and we should not sit in silos doing our stuff and don't know what the others do. So start to go together, let's support each other. This is the thing what we need to maybe move a little bit more forward, maybe also a little bit more fast.
It's so true, but the other thing I'm going to say against together and common is don't forget what you bring is not the group think. That's the new idea, the new approach. So that's your superpower, right? That none of us can have. Front row.
Tim Hubbard, King's College and Health Data Research UK. What Lawrence said about unconsented and citizens is pretty much what we're doing now in the NHS. We're running citizens' juries to discuss what's acceptable uses, to co-design, and then that affects unconsented data with opt-outs. Problem comes that patients don't trust if the data gets distributed, because in the US maybe you can sue everybody, but there are examples of companies misusing data. So we've adopted this access model, and that's implemented for large systems now in the UK. The data doesn't move. Now, the European Health Data Space has the federated model like that. Isn't that enough for a lot of cases to federate, rather than talking about transfers, which causes all kinds of trouble, to talk instead about federated access to different systems to do the analysis that way?
So panel, we are at time. I'm going to ask you to say perhaps just one word. Yes?
Yes.
Yes.
That's what we're working on.
Okay, and I'd like to take one more question because he was raising his hand very early. I'm sorry to cut you off, but there are 7 more now, so... Okay,
I'm sorry, we take one very final question.
Yeah.
Thank you. This is George O'Quare from Scripps Research. A super interesting discussion. I was trying to understand, so if we are questioning this concept of consent, what would be the message for people who don't want actually to share their data, and what could be the consequences for them? Are they potentially mistrusting the health system? This is for all panelists, whoever wants to.
For those who opt out, you mean?
For people who don't want to share. What's the message for those who don't want to share?
Well, they have the choice. They don't get any disadvantages, but there's kind of a weak moral duty maybe to share your data if you don't experience any real risk. So that would be from the ethical point. You could make the argument that it's kind of a citizen's duty to help others as long as you don't down or there are not real high risks on it.
And Susan?
Yeah, rather than give you a stick, let me give you a carrot. In particular, and this is a way that I think we're going to move forward writ large, but at least within all of us, when you share your data and you allow researchers to utilize your data, you not only get to see how they're using their data, but guess what? We give you results back. Really important results about your health in the context of what's seen in all of us. And that's a carrot for you as a participant, because people who will participate in the All of Us program aren't patients. They're collaborators with us, and we value that.
Just to bring in the insight of Data Saves Lives, both projects, we have the European and the German one, but we see in our daily work that most of the people living with diseases would be open to share their data. It's not the problem for them. They see the necessity, and also they see that they can help others. And I think it's a big piece of communication we have to do for those who are doing an opt-out at the moment. But what I see is there is an absolute positive attitude, and maybe we should use that wave also to go out to communicate that a bit.
Fantastic.
I would start pointing out, as my friend from Roche did, there already is sharing without consent. And so I think the question is just what the line is and how closely the public even understands what that line is. And I would challenge the assumption that there's an automatic erosion of trust depending on where in particular that line's drawn. Instead, I would again urge we think about institutions like it seems the NHS is doing in Britain that could build trust by people seeing that the right kind of people are making the reflective judgment informed and without interest that could help draw that line in a way that people have a reason to trust.
Thank you so much. Chikwe, I offer you the last word.
My last word won't be on this question, a very important one, but just so that we really urge all of us as we have these important conversations on an individual level to also think about it as at a population and sovereign country level, because we really need global consensus on lots of these issues as well as the individual incentives. Yeah.
Panel, thank you so much. Audience, I hope you'll join me in thanking the panel because they've been excellent.
Thank you so much for this very interesting panel. We switch. I hand over the mic to you, Naomi. You take my Q&A.
Thank you so much. Enjoy your panel discussion.
Talk about transfer of research into practice and innovation into healthcare right now. We'd like to highlight positive use cases and best practices. And I do that with Rolf Abweiler, the director of the European Bioinformatics Institute in Cambridge in the UK, which belongs to the European Molecular Biology Laboratory. Welcome, Rolf. Nice to have you here. Take a seat. Nisar Malak is the managing director of the Department of Internal Medicine and the Department of Gastroenterology, Hepatology and Infectious Disease at the University Tübingen. Welcome, Nisar. Then I'd like to welcome Fulvia Raffaelli. She's a member of the European Commission and head of the Digital Health Unit DG Sante. Welcome, Fulvia. And last but not least, Shannon Thor. She's the Deputy Director of FDA's Europe office in Brussels, where she leads a team in strengthening the safety and effectiveness of medical products and food produced in Europe for export to the United States. Welcome, everybody. Nice that you're here. Thank you very much. And I'd also like to start by asking you, would you first please introduce yourself or introduce us to your work and tell us about your perspective on what it needs to transfer innovation into healthcare?
Sure. Thank you. Thanks for having me here. I'm really excited to be part of this panel today. I work in FDA's Europe office based in Brussels. I don't know if you all know that FDA has a presence in Europe. We have a small team based at the US mission to the EU in Brussels, but we're a regional office covering all of Europe. And in fact, we have an FDA staff member embedded within the European Medicines Agency in Amsterdam as well. And what the purpose of our office is, and what I'd like to really highlight in my comments today is the importance of engaging with regulators early and working globally when thinking about how to approach innovation and regulation of new technologies, and when considering the use of health data for regulatory purposes. And I hope you don't mind, I brought my notes here because I want to make sure I highlight all the things, I'm not a health data expert myself. What we do in Europe office is make those transatlantic connections with our folks back at headquarters and encourage collaborations across Europe. And it also is nice because it doubles as a fan. So I know we're all hot in here.
And we heard a lot about cultural change that needs to be done. So we might come back to this as well.
Yeah.
Rolf, it's nice that we have you here. Introduce us to your work, please.
Okay, so my name is Rolf Abweiler. I'm, as already mentioned, together with my friend and colleague Hugh Burney, leading the so-called European Bioinformatics Institute, which is close to Cambridge on the Wellcome Genome campus. And we were asked really to highlight positive use cases and best practice. And so maybe I start with that. You may be surprised, but international data sharing works wonderful in the life sciences. So we share structural data since 1971. We share genome data internationally since 1982. EBI was founded in Heidelberg for this purpose. NCBI, first DOE and later on NIH, founded a GenBank that we work together since 1989. Protein data is shared, other omics data is shared, literature data is shared. So when I started in Heidelberg working on what's now called bioinformatics, we shipped 400 tapes to users worldwide. Nowadays, we have 107 million web requests daily to the EBI websites, serving 40 million IP addresses a year. So every 5 minutes, an article is citing these shared data resources. Every 3 seconds, we get a new data set, and it's freely available to everyone. So we wouldn't have all the wonderful outcomes of projects like the Human Genome Project really being a game changer on how we can understand diseases and so on. AlphaFold wouldn't be possible without the public data in the PDB and in UniProt. So we have examples of this transformation. No single medicine nowadays is developed without accessing the shared public data. None. Also in the clinical research space, we have already a lot of sharing. A lot of cohorts get sequenced, and they end up in the Federated European Genome Archive. It was started at EBI, then it became a collaboration with Barcelona. Now it's the German side. You heard already a few times about the German Human Genome Archive, which is part of the FEGA. And it's federated, the data stays there, but they share the same system how to access the data. So we have already a lot of positive examples, but we are talking here about healthcare. And there I think the problem is that research and health ministries are not necessarily talking enough with each other. Because at the moment, it's still thought in most countries that research delivers something which goes later on into the clinic, but there's no way back. And from the pandemic, we learned that countries which behave differently, which have a one health view, one research view, working together, they created a lot of data. Most of the interesting data came from the UK, from Denmark, from Israel, where they had these barriers ripped down. So how do we get there? That needs a cultural change, that people understand that the GP offices and the clinics are huge phenotyping centers which can be used for driving research. But that means also you need to incentivize people to do it. People there are paid and equipped to care for their patients. They are not paid and equipped for gathering data for secondary use of the data. And that's where I think we need to make a cultural change and do something about.
How to overcome this, how to do, yes, that's right, how to do the cultural change. We like to dig deeper into that right now. But maybe, Nisa, you'd like to add up on this. You enabled mutual data access between several university hospitals as well.
Yeah, thank you very much for the invitation to this wonderful conference. My name is Nizam Malik. I'm the head of the Department of Internal Medicine at the University Hospital in Tübingen. But today, I think I'm here because of our almost 10 years experience in setting up a national network, first a regional network, but then a national network that is trying to introduce personalized medicine into healthcare. So we were explicitly not starting this network for research purposes. This is also something we are doing, of course, but for trying to bring personalization into healthcare. And we started with oncology because that's the area in medicine where biomarkers and molecular-guided drugs are best established. And what we learned in this process, bringing together now 29 university hospitals in Germany, is that data is absolutely essential for running an endeavor like that. Because if we want to make a decision in oncology based on, say, genomic sequencing of a clinical specimen of a tumor, we need to collect all the experiences that we are gathering in all these different hospitals and make them accessible to the individual researcher and doctor for many purposes. One is we want to make better decisions for every future patient. So every patient benefits from the collection of the data in this group. And so by this, we are making ever better decisions. And we also want to improve clinical trial inclusion, because every trial in oncology, but also in inflammatory disease, on aging, is based on genetic stratification these days. So we need to find these patients, and we need to find them on a national and maybe even international scale. And we also want to get information from these types of data on signs of hope. We are using a lot of drugs in indications where they are not approved. That is a possibility in Germany. So we can learn from this data also for research purposes. But putting this up or setting this up in a university hospital setup is tough. It's really hard. And this is really the point that I'm trying to make here. All the ideas that we are discussing, which are all great, have to live up to the standards of a treatment system, of a healthcare system. So we should not, I think the current word is dream, about results if we do not have the data, because we do not have the people that put the data into databases, or we do not have the systems that define which clinical data we want to connect with the genetic data. And I think a very important aspect here is, and that I don't think it has been discussed here so far, is reimbursement. All of this has to be paid for, and every healthcare system in the United States, in Europe, in Germany, everywhere is run on money. This is all a money-driven system. So yesterday, a colleague mentioned that only 3%, I think, of the data that is available is analyzed. My claim would be it is because nobody pays for that. So when we set up the Centers for Personalized Medicine in Germany, we engaged into discussion with the health insurances right from the beginning. Because health insurances cannot longer be seen just as a negotiation partner in a fight for funding. They have to be seen, I think, in my eyes, as a partner insofar as that they have to be convinced to engage into the creation of a healthcare system that is also trying to create knowledge and not just paying for certain procedures and so on. And my last point is, all of this has to follow quality control and quality assurance mechanisms. If we are talking about science, it's one thing. If we are talking about healthcare, in Germany we have a very differentiated system in oncology that is over and over tested by certification systems. This also has to be applied for everything that comes out of these discussions. Otherwise, it's not healthcare; it's research. So those are my main points.
You're tipping critical points here. I'd like to take them into the discussion right now. But Fulvia, can you quickly tell us about your work? You're joining the DG Santé with the European Commission.
Well, first of all, thank you for inviting me. This is a wonderful conference. I must say that I have been in several panels in the last months, but this one is very interesting, particularly interesting this morning. I have indeed the honor and the privilege to lead the team, the European Commission, that is on one side negotiating the European health data space regulations with the Parliament and Council at this point in time, but also already thinking about implementation and driving in many of the projects and the joint actions that we are already in the making, let's say, with member states and stakeholders to pave the way to the implementation. Let me say three short messages around the HDS. I think I don't need to come back again on the issues that data are the future of medicines and of public health. A lot have been said, and I think we are fully convinced about it. And the European health data space is the tool that we have designed to actually make that happen, so that not only some stakeholders, as the one next thing to me, have access to those data internationally, can indeed make the research, but that this community is open up also for SMEs and startup maybe, or for smaller research centers, so that the data becomes really a value for the community as such. So we are very much engaged in that, and we believe that's the way forward. But indeed, there is a risk, and I'm referring to the panel that was just before, that we set up a big, as we say in Brussels, machine à gaz, so a big complex regulation with many layers, and then at the end it does not deliver in practice, so that it becomes an empty box. So we really need to design together and to keep these benefits for societal benefits. And I can't agree much on the fact that we need a fair balance between individual benefits and societal benefits to deliver really in that sense. And to keep that the citizens, and I like also the reference to the citizens, not to the patient only, but to the citizens at the center. So as a healthy people today and as a patient tomorrow. So this is, we need a setting which is efficient, that is implementable, and is also future-proof, so that will actually pave the way for the use of data in these areas, which is moving so quickly. The last point is is that we need it now. We need it now because these innovations is accelerating, is happening already, not only because of research, but because of many different objectives, including more efficient and cost reduction in the health systems. So data are produced, they are there, and we need to create a solid framework that actually allows the use, the access of those data from a citizen perspective and from a societal one. If we wait too long, if we miss the 24 opportunity in Europe, then we may face a much more complicated situation with even more fragmented regulatory environment in Europe and across the world.
I think everyone agrees on that one. We need to start now. So I'd like to start to dive deeper into that. And Rolf, ask you how you pointed out that systems are running and you're already collaborating with a lot of people. Nisa, you said that too. How did you set up the systems first?
Well, I think this was really organically grown. Molecular biology was from the beginning driven by open access. The first manual of an embryonucleotide sequence database said, this manual and the data coming with it can be freely and openly redistributed without any restrictions as long as you copy this statement. And I think that was the basis for a lot of success. Tim sits over there. He was deeply involved in the Human Genome Project at the Sanger Institute. So we had the Bermuda Principles, we had the Fort Lauderdale Principles and the Toronto Principles, which said, look, we are building community resources and the benefit needs to be to everyone. It's not for fostering the activities and promotion of individual researchers. We build community resources. And that happens also with cohorts. And that's also, I believe, the idea of things like the European health data space, that we say, look, we need to harvest all of this investment in a different way. And I completely agree with you that we need to find ways to have people to find the time, the money to do it, and the skills to do it. So a lot was spoken about consent. I think trust and trustworthiness is the basis, but I think this is all manageable. Yeah? But not without a cultural change that research and health see themselves as communicating columns and not anymore as silos. So that needs to happen.
Yeah, Nisa, you brought up the price tag question. So don't you think that's more of a chicken and egg problem? How would you describe it?
Well, obviously somebody has to start and has to convince somebody else to join in. We did this in Baden-Württemberg over a 3-4 year process in which we sat together with all the relevant people from the government, from the health insurances and so on, and the academic institutions, and try to convince them and each other and all of us that this is something worth doing and is something worth financing. And obviously this has to be checked. It has to be controlled. It has to show that it works. And I think I would add that to what was just said. Money, time, effort, but also we have to show that it's good for something. I mean, in medicine, everything has to show that it's good for something. It's not just collecting data. I mean, we can do all kinds of stuff all day long, but if we want to do this, it has to show that it's beneficial. It's helping the patient, it's helping the doctor, it's helping the system. And this is, I think, also part of quality control. We have to make sure that all of our ideas that we are pushing here really lead to a beneficial effect for the patient at the end. And I think that hasn't been done enough. Maybe also because we don't have the appropriate measures to do that. And maybe we have to develop that. That's maybe something for the FDA and the other regulatory agencies, also for the European Union to do.
So how to find the right measures? What are the right measures then?
I mean, in oncology, I can tell you what the right measures is. It's progression-free survival, it's overall survival, and that's what we are using for our system. Do the patients really live longer if we see them in a molecular tumor board? If we do, what's the difference in if we just sequence 50 genes or 30,000 genes or all genes, and then also transcriptome and proteome and what else? All of this can be done. Not everywhere, maybe, but in an ever-increasing number of places. But is it really good for something? And that has to be shown. And I think if we show that, then it will also catch on, and then people will do it.
Mm-hmm. Shannon?
I take your point. And at FDA, I think on the drug side, we're really doing a lot of global engagement to find that. How do we know that the evidence is translating into effectiveness for medicines, right? And so one of the things we do in our Center for Drugs is we have this longstanding collaboration with the European Medicines Agency and also Health Canada. They meet regularly in, they call it a cluster. And what they do is it supports regulatory decision-making through the development of new approaches for assessment of evidence derived from real-world data and other big data sources. And so this consistent collaboration allows them to think about advances in regulatory science and how to use those, how to have a consistency of approach across regulatory jurisdictions. And for the last year or so, they've been working on a reflection paper for ICH. And I don't know about you all, but a lot of my colleagues have been in Montreal in the last week attending the ICH meeting. And so yesterday, ICH just published this reflection paper, and I think this will spur a lot of converging work in this area. And so I'll read you the title of it so you can look it up later. But it's called The International Harmonization of Real-World Evidence Terminology and Convergence of General Principles Regarding Planning and Reporting of Studies Using Real-World Data with a Focus on Effective Medicines. So that's a mouthful, right? It sounds like something that FDA would put forth through a regulatory speak. But really, the end point there, the focus on effective medicines. And so this is a strategic approach to address these challenges in standardization, in terminology, and heterogeneity of data quality. And so I hope that you'll take a look at this paper. It's available for public comment. And we look forward to your thoughts on that and to see how standardization can lead to more effective medicines.
Speaking of this, do you think we need separate sector-specific tools or different certification processes? And what should they look like if we do?
Mm-hmm. Well, I think that's something that's, up for debate. At FDA, we have, different centers across the different product lines. We have our Digital Health Center of Excellence, which came up out of our Center for Devices and Radiologic Health. And, when there's a lot of innovation in the space and a lot of public need for us to sharpen our regulatory tools, that's how the Center of Excellence was founded. And they're putting forth a lot of guidance on how we can have an integrated approach across the medical product centers.
Mm-hmm. And Fulvia, from a European perspective, would you agree? And would we need different certification processes for AI applications than for medtech and pharma products, or is it sufficient if medtech and pharma licensing included complementary requirements? What do you think?
Sorry, I didn't hear much.
Oh, so I just asked you to add up to this. Do you think we need different processes for AI applications than for medtech and pharma products? What do you think from a European perspective?
Well, the European Artificial Intelligence Act is about to be adopted. You certainly read on the newspaper, and this would be again the horizontal, let's say, legal basis for us to act. Into the HDS, we build up upon this regulation, this horizontal regulation, and we indeed foresee the possibility of using artificial intelligence in the context of the data space as one of the uses, which requires a particular risk assessment, but it does happen in the same framework as this other research. So it's one of the different typology of research that can be, let's say, covered in the legal framework of the HDS. This is the way we do it in Europe. We have horizontal reference legal basis as the GDPR or the Artificial Intelligence Data Act indeed, and then we build on those horizontal to look at the specificities of the sector and hear about the health. And maybe this gives me the opportunity to highlight actually the fact that for the European health data space, indeed, we build upon, we've heard a lot before on the GDPR, so on the existing possibility actually to move in a direction of not having a consent-based approach, in particular for the secondary area. So I think that it's important to remind that those horizontal legal framework at European set up the basis for more tailored approach. And this is what we're aiming to do with the European health data space, that actually focus very much on the needs of the researchers, innovators, and of the future of that disciplines, let's say.
As you just mentioned, the EHDS, can you tell us more about what the current status is?
Well, we are full speed in the negotiations with the Council and Parliament. We are confident that the two legislators will formalize their position in autumn, so that we can conclude the negotiation before the elections in 2024. I think now more and more we are sort of focusing on the parts which are more under discussion. So I think on the Parliament side, this is indeed the issues around the opt-out and the possibility for citizens actually to control their data, to restrict their data also for secondary use. While on the Council side, I think the issue is more around the compatibility with their legislation, so to see how much they would need to adapt and to actually shape, let's say, their own systems, existing systems, and in particular for the member states that already have systems in place towards the future one. I think these are the main areas of.
So the secondary use is especially interesting for transatlantic collaboration. Can you tell us what the relationship of the EHDS is to the US-EU data privacy framework and what is currently being negotiated?
Well, for the time being, this is a conversation that is ongoing in the context and in the framework of the GDPR, because the HDS, it doesn't exist yet. Actually, the moment the HDS will be in life, it would indeed create a sort of dedicated channel for conversation. On one side, it would, in our proposal, the access to secondary data, data for secondary use is open to users without qualifying whether they are EU or outside EU. So the same rules that would apply to a European researcher would also apply to a third country users of data, with the same constraints, of course, and the same safeguards set up in terms of access to data. So not transfer, but access that is possible at the same condition as the European. And then there is also a further opportunity to become, actually here more for a country, to become part of the system as such, under very strict conditions and with agreement of the member states and the other participants to the system. But this is as I was saying, creating a dedicated, let's say, a channel for this specific data.
Mm-hmm. Shannon.
Yeah, I was just going to chime in that it's really great to hear that you're building within the architecture of the European Health Data Space mechanisms for sharing and being able to have access for third countries. So we're really interested. We're paying a lot of attention as you develop the EHDS, and we're interested in exchanging with regulators because it's not just the access but the quality of the data that's there. So we're interested in sharing, exchanging ideas, brainstorming on data standards, data quality, interoperability, we look forward to those international exchanges, with the necessary safeguards in place, of course. And so we hope to be engaging with you more on that in the future.
Thank you for sharing this. Let's come back a bit more to the question how transfer of research into practice is working. And Nisa, you pointed out that, or you are a member of, no, I'm sorry, Rolf, you are a member of the Protein and Nucleotide Data Group, PANDA, since 2007, and you pointed out the importance of networks as well. So how do these networks help us to put research into practice?
Well, as I mentioned, everyone is free to use the data, and of course, all companies which do drug screening, they take the public data for virtual screening against existing structures and now also against models. That's just one example how it's done. But I wanted to come to one point which was brought up before, and what I think is also really an important distinction between the success of the molecular biology field and other areas, and that's the use of open standards. We agreed very early on interoperability standards, and they are open. Nobody owns them. Some people mentioned already the Global Alliance for Genomics and Health, which again creates that. But we don't have the same things for electronic health records, if we have electronic health records at all. We don't have that for, let's say, imaging technology, which is more or less proprietary. And I had it for, I created many years ago as part of a UPO, the Proteomics Standards Initiative, which is still strong. And all the mass spec vendors are now also producing outputs in a non-proprietary format, which is shared across the community. And I guess all of these efforts are really necessary, because even if you're allowed then to share or to access the data, if you have everywhere different standards, you can't bring just your algorithms to the data if you really need to massage and wrangle with the data again and again and again. And that makes it all very costly. So, and again, this is, since research has very limited money, you had to find ways to do it with a little money. The money which goes into the healthcare system is used for other purposes. So they are not, they just have not the headspace for dealing with that. And that again points out to what I said before. This needs to be addressed together by the governments as a task for the health minister and for the research minister and probably also for the education minister, because you need to have also trained people, and probably more stakeholders which should be their justice departments, for example. But it's more break down the walls between the ministries and talk more with each other. Then you can be successful.
I see you nodding, Nisa.
I would also add the Minister of Economics to this list, because one of, I think, the big obstacles right now is an enormous amount of distrust between the pharmaceutical industry and the health insurances, because the data, at least in Germany, that is produced in hospitals, in practice and so on, is paid for by the health insurances. So if we are now using this data and put it into accessible databases, then clearly the pharmaceutical industry is very interested in this because, for example, in our case, we have a lot of data on off-label use for certain drugs in different indications. So that could be very helpful in trying to find or devise new trials, clinical trials, that would prove that this drug helps not only in breast cancer, but also in colon cancer, because we see the same mutation or the same pattern of mutations. However, bringing these together is very difficult because they are, at least in their opinion, in different sides of the spectrum. And so I think now politics would be good, or politicians, to help show that there's a mutual interest in using this data, and that maybe pharmaceutical industry could help us to fund more innovative trials and provide us with the required drugs, while the health insurances bring in the data from patient care. And if we bring this together, maybe we get a step further in a faster way. But this is something that academia is trying, yeah, but I think this is a political problem. We have set up something like that in our state, where the Ministry of Health, the Ministry of Research, and the Ministry of Health and Economics are talking to each other and funding projects like that. And this is a small step, but maybe we should do that on a national level or maybe even bigger. Yeah.
Yeah, Shannon, you'd like to jump in there?
Yeah, sure. I'd just like to flag that just last month, we hosted the HHS Secretary, Javier Becerra, in Brussels to meet with the Commissioner Kyriakides from DG Sante, and they established this US-EU health task force, and it's got 3 prongs. I think a lot of it has to do with pandemic preparedness and also health architecture, but the third one is cancer. You know, the US's cancer moonshot and the EU's beating cancer plan, and so I think there is cooperation at that level, and hopefully those conversations will have maybe a trickle-down effect to serve your other points. Yeah.
Yes, I think this conversation around also the standards and the format is very, very important, because this is an enabler about making the data space existing in practice. And one of the idea of the European health data space is actually to define a single European format that would enable the exchange, the cross-border exchange of data for primary use, but also that would progressively and maybe with a timely approach to also help the different data holders to prepare the data in that format. Some parts of that standard exist already on a voluntary basis in the context of the My Health at EU, so for e-prescriptions, for patient summary. So we have guidelines existing in Europe that would up and running, let's say, for testing. For the time being, there are 11 or 12 member states that are actually using those guidelines, but they are the first steps in that direction are ongoing, and we're working very closely with the standardizers, let's say, community around the world, because of course the last thing we want is to reinvent the wheel. We will definitely build upon existing standards and existing community around it, so that we can actually build upon those efforts already and maximize the synergies.
Before I go to the audience and open for the Q&A, I'd like to ask a last question, because I can see that there's kind of a balancing challenge between bottom-up solutions and top-down solutions. Where can we find the right balance in between these?
I mean, with respect to Germany, I would say we are seeing this right now. Rolf is in the advisory panel for the Genom.de initiative, which is just now trying to provide input into a new legislation that we will have in Germany starting in 2024, which brings genome sequencing to patients with rare disease and with cancer. And a lot of what is now used for bringing this to the national level is based on regional initiatives from different areas, from rare disease, from cancer, and so on. Infrastructure is put together, experience is put together, and so on. So there was a bottom-up approach which dealt with particular questions. How can we help female patients with inherited breast cancer? And then they set up a database for that, and so on. And how can we help patients with rare disease? And now the government came in and put this legislation in place and said, health insurances, please pay for genomics analysis for these patients. And now these two areas merge. It's very different from, for example, the English approach, which to my knowledge is very much top-down. And then there are other approaches where it's probably some bottom-up, but not yet a top-down approach. So there are different varieties of this, but in Germany, this was the way it went.
Vivian, you noted as well.
Yes, we are reconciling these two approaches indeed, because we definitely try to maximize the experiences which are ongoing, including the different registries, existing registries. So these are very important the repository already and experiences of sharing data, which are very well recognized from cancer, but also for genomics, etc. So these are our experiences that we want to build upon. So we definitely have this bottom-up approach, but then we have also also this top-down that actually set the horizon, let's say, a common direction for everybody to go. I think that's where the HDS can play a role, and that is also why we need it now, before all those initiatives, which are very important, sort of get too much away from each other. So that's the moment now to set a common objectives, including a common format for exchanging the data, so that we can indeed build upon those very interesting experiences and get to the potentially bigger data lake around the world.
Mm-hmm. Shannon, you wanted to add something?
Oh, yeah, sure. So I mentioned kind of the big top-down approach of the US-EU Health Task Force. And then also at FDA, we're modernizing our agency. We have a data modernization action plan that offers enterprise-wide solutions to dealing with big data across the agency. But I think at FDA, we're really, we pride ourselves on our public engagement and getting stakeholder perspectives into the agency. So I guess I would draw your attention to a discussion paper that we just released last month in May 2023 on using AI and ML in the development of drug and biological products. And so the paper is aimed at spurring a discussion with interested parties in the medical products development community, such as pharmaceutical companies, ethicists, academia, patients, patient organizations, global counterpart, regulatory and other authorities. So everybody in this room, I think, probably falls into one of those categories. So we're interested in what you think on use of AI and ML in drug and biological development, and also even the development of medical devices to use with those kind of treatments. And so, you know, we put this out there for your comments, and then we're planning a series of workshops in the future to further that discussion. So I think that's how we enable our bottom-up approach.
All right, thank you for sharing. First question here, and then, yeah, we have a few.
Thank you very much for a very interesting and insightful panel. My question will be directed to Fulvia. My name is Björn Escofier. I'm a professor at University of Erlangen for machine learning and data analytics. I'm also a research group leader at Helmholtz Center Munich for translational digital health. And my question is revolving around my role as a spokesperson for the German Gaia X Lighthouse project, Team X, which is an abbreviation for Trusted Ecosystem of Applied Medical Data Exchange. That's an 11 million euro, three-year project to build implementation of a personal health data space. And we're, of course, looking towards the regulation of the EHDS to make it compliant. So my question is, the EHDS is a fantastic regulatory innovation. But what about the technical architecture for it? What's your viewpoint on what companies and startups maybe will need to develop to actually build this technical infrastructure? What are the low-hanging fruits, and maybe also a little bit the higher up-hanging fruits that you think will need to be developed in order to make this a thing across Europe? And also what, now you're speaking to a lot of academics, what would you wish for from the academic pre-competitive space? What is still needed in research in order to make this a thing? Thank you.
Very complex question, Fulvia.
Yes, indeed. Okay, from a technical point of view, as I said before, we have already a few projects up and running looking to the technicalities of the digital infrastructure that would build upon the existing My Health at EU for primary and the future health data at EU and digital infrastructure for the secondary use. This is there are a lot of projects where also member states, also stakeholders and manufacturers are involved. We also have a stakeholder committee where we're collecting evidence from the market as such, and we are the intention to really settle the rules for a much open, let's say, market for those services that would, by defining the references at a technical level, at the European level, then it would create a much more dynamic, let's say, market for the emergencies of services which are connected to the use of secondary data. I think what is, so we are, let's say, trying to use a maximum of expertise around the table. The health network is, for the time being, the reference groups of experts that is working on it, but will in the coming months and after the adoption, of course, working even more closely to the market operators so that we can also use their expertise. Implementing Act has now been discussed, so let's say the powers that would be delegated to the Commission are still discussed now in the context of the negotiation, so we don't know how far the Commission will have a say in these areas, but definitely we are building up a maximum of technical expertise in-house and in cooperation with the experts so that we can come up with something that is very pragmatic. As at the core of everything remains the keywords, which is implementability. So let's make it real.
Yeah, thanks.
My name is Julian. I'm running a national primary care provider here in Germany. And I think the problem of bringing research into practice is rewarding also for this. So last year we have seen 100,000 primary care patients, and my incentive to have them use a AI symptom checker is 0. My incentive to give my doctors a data-driven decision support is 0. Why would I do it if it just costs me money and nobody rewards me for better health outcomes, for happier patients? And this is not because we're a large organization, it's the same for individual doctors, like even the other way around, like we do have the means to actually do this and implement this, and we will eventually do this. But I think we are kind of neglecting this part of the journey of actually bringing it to the patients, right? So this is a very academic round, but I'm interested in your thoughts to go the last mile, because this is where the magic happens. If we want to manage a diabetic better, this is where it's happening.
Yeah, thank you for this extremely important question, because most of care that we are providing to our patients is not provided at university hospitals. It is provided at community hospitals, and it is also provided in private practice. And we know this for many years. And yesterday there was a very interesting lecture by the colleague from the Mayo Clinic who showed us that he's overseeing this large network of hospitals that are also providing data. A very practical problem. I mean, at the end, it all comes down to practical problems. You know that. How do you get the data from a private practice into a university hospital center in an appropriate way? One big problem is that we have a plethora of different systems, IT systems in these practices that prevent that. Maybe if you have a more organized setup, it's easier, but we are now setting up in Baden-Württemberg a project where we are trying to get at least the 17 most common practice information systems so that we can actually automatically extract data from these practices into our data infrastructure without causing more work and problems for the doctors. And then plus, if we want more to be done, obviously we have to incentivize that, and that usually means money. We are coming back to money. So if we are now negotiating the next contracts with the health insurances for the oncology branch of ZPM, it will include a documentation fee for the private practices so that they have an incentive to actually help us.
Or if you might like to add something?
No, I completely agree with that, but looking again at Tim, he probably also remembers when Edinburgh's introduced EPIC here as their electronic health records. The productivity went down by 1/3 for a while, and the COO got fired, and he was aware that he will get fired. So, but it was in the end. It now works. It increases productivity. It allows now access to data for secondary use in research. But it's really painful, and you need to be aware that it costs money and it will be painful, and you need to take the people with you. Yeah. So all the staff and the patients, you can't have 100% booking when you introduce that. So you need to be aware we will not be able to do 100% because there will be glitches. They will be there.
Mm-hmm. Thanks. Another question here?
Hello, Konrad Förstner here, a speaker of NFDI for microbiota, and Rolf has mentioned this very nicely, that in certain parts of research, sharing is very natural and ongoing since decades. And in Germany, we have the National Research Data Infrastructure, NFDI, and it was mentioned also yesterday that basically there is no data that is not health data. Everything's influencing health in a way. And with the European health data space, we have now another platform. And my question to the panel would be, how can this be all integrated? At which kind of forum can we come together? Do we have such a conference now every month? Or how can this be all aligned? Because we are having this plethora of data. We have many different initiatives. How can this be used to aim for this joint goal of making better health solutions?
I'd vote for the conference. What do you say?
Well, first of all, of course, this is you need to connect with your German national authority here, because I think it's important that they we know, in particularly in federal states or where in states where the responsibility is decentralized, then actually there are in many cases tension between the central system and the decentralized. So I think I would definitely advise, first of all, to get connected with your authorities so that this is well represented, and then when the European health data space will become reality, then it would be easier so that you are also prepared. We know indeed, and you mentioned that in Germany there is a work ongoing to prepare the national legislation, and we know actually that there are intentions to already prepare to make that legislation fit for the future so that we can already set the intention. This is ongoing in several member states. So this is something that is very, very important. So we have, I mean, the Commission at this point in time is playing the honest broker role in facilitating the agreement, in pushing and in keeping the ambitious, because there are still risks that for many different reasons. Actually, we may face a slowdown or a reduction in the ambition of the project. So our role is really to highlight the benefits, and I would say the societal benefits. Sometimes we see an opposition between the primary use, which is considered to be for citizens, and then the secondary one, which is considered to be for research and maybe pharma companies. I think this is very wrong, because the objective is, at the end of the day, citizens at all costs. So also we want to facilitate research and innovation for the benefit of the citizens of today and the patients of tomorrow. So I think there is no contradiction between these two objectives. Quite the contrary, they are supporting each other. And this is something on which we need really your support to make the message passing across. Sometimes we see a certain similarity with the syndrome that I'm sure you know very well from the environmental discussions, the NIMBY one, not in my backyards. So please do your research, because tomorrow if I'm sick, I want to benefit, but not with my data. You know, I think this is really something that we need to get across as a message. The data are produced today for many different reasons: treatment, diagnosis in the first place, and then let's make it the maximum out of those data.
Mm-hmm. Thank you. Another 2 questions.
So, Rolf, you said that it's difficult to get the culture of these two, the research side and the health side, working together. This is still a work in progress in the NHS, but we do have an exemplar from Genomics England where we set up the structure. Genomics England is not like UK Biobank. Genomics England is doing a clinical service for the NHS, which is now full national service, the genome medicine service with the NHS, whole genome sequencing for rare disease and cancer. The point is that we have a lot of undiagnosed rare disease patients. But all that data, if there's consent from the individuals, is also in the National Genome Reference Library, accessible to researchers and companies. And there is a mechanism if every individual is flagged if there is no diagnosis. And there are 2,000 cases where a company or an academic identified something that our automatic pipelines did not identify and have passed that information back for clinical care. So if you build that kind of cycle, then you stimulate the health service workers because there's something in it for them and for patients that is not just a drug in 20 years' time. So the question is to the Commissioner, you're talking about in the regulation separate things, sharing for individual care and secondary care. Are you building in a mechanism like that so that the researchers can potentially send back some information to clinical care?
Yes, under certain conditions, of course. So this is it is possible. Well, first of all, we have foreseen a possibility, well, actually an obligation to make public the result of the research. So at the end of the research, the main outcome of that will have to be made public on the common platform, which is already let's say, a more transparent approach if compared with today. And there is also in the proposal the possibility for the national authorities then to also decide if some of the results of that research would be needed for the patient adoration. So this is one of the few exceptions where re-identification could be allowed when there is a benefit for that specific patient. So this is something that which is foreseen in the proposal. To be honest, I'm not sure it's going to survive until the end, but this is something we had in mind when designing the regulation. And then, yes, there will also be possibility to reuse those enriched data under certain conditions, of course.
Thank you. Last question here.
Benny Levinson, the topic of this session, there's a term for that, and the term is implementation of clinical guidelines. Nobody mentioned this term so far in this session. And we always need to keep two questions in mind. Question number one, why are we doing what we are doing? Question number two, how are we doing what we are doing? And this covers culture change as well as quality assessment programs, but it also covers the implementation of clinical guidelines. And maybe my specialty, cardiology, is very far advanced like oncology is. The others maybe are not so far. And I would like to give you 3 short examples for initiatives to improve everything. Example number one, in 1995, the Society of Cardiologists in Private Practice in Germany launched a computerized quality assessment program in the cath lab. So far, we've collected millions of files, and this led to a better healthcare of patients in the cath lab. Example number 2, 6 years ago, also the German Society of Cardiologists in Private Practice in Germany launched a cardio coach app where doctors and patients get together to exchange clinical files, results, asking for a prescription, so on and so forth, on an app basis. And number 3, the American College of Cardiology, 4 years ago, launched an international initiative called the Global Heart Treatment Initiative in patients with STEMIs, with infarctions, addressing specifically countries with low and middle income to improve cardiac care in these countries. And we all know, and that's like carrying oaths to Athens, that only by taking part in programs like that, you improve in what you're doing. And this needs to be a bottom-up solution. Politicians, as Karl Lauterbach, can step in at the moment where you have the grounds. And he's stepping in by taking patronage on the German Heart Alliance, which is going to be launched this year to improve healthcare in cardiac patients in Germany. So I think that's the solution, but it comes down to implementation of clinical guidelines.
I'd like to take that one as a question for last little quick fire, maybe just one sentence to that, because I wanted to ask you, how can we achieve regulatory convergence? I take that how we can achieve implementation of clinical guidelines. Nisa.
Well, I mean, I couldn't agree more. I mean, and for, as you said, I mean, for oncology, we have a myriad of guidelines at a very high scientific level. We are now in the living guideline area, you know, where you are updating them continuously. Myself, I'm coordinating a large guideline project and so on. It's a lot of work. In this area, molecular guided medicine, molecular tumor boards, molecular inflammation boards, and so on, There's a sparsity of guidelines at this point because we do not have the methodological technology to really come to guidelines, because we're talking about personalization, we're talking about very few patients. So how do you make a guideline out of a patient where you only have 5 patients in the world or 5 patients in your database? So there we need to come up with something else. It is not really guidelines, it's more like Leitplanken in Germany, yeah, like side rails, yeah, where you give the physician an idea on where the field stands, and then based on that he can probably get some help for his decision making. But
so
quality control, yeah.
Yeah, to put it in a corridor. Fulvia.
This is I think coming back to the idea that implementation remains the key words here, and we need to work together to build upon those experiences, very successful experience that we have it already. We know that sharing of data can be very efficient, of course, for rare disease, but also for very specific areas, and we know that this is the future. So let's really focus on the practical. Let's keep very clear in mind what the benefits for the societal are, and let's maybe put a bit of aside our individual, let's say, concerns in relation with sharing the data, although under the very clear safeguards that we have created. If we want to do more in that area, let's discuss it, but let's do the work that then would be really useful for the researcher afterwards, because if the result is data quality, which is not good enough actually to support the research, then well, a lot of work for nothing.
A lot of work going to be done there. Thank you very much, Fulvia. Just a short answer, Wolf.
Well, I think implementation is, of course, key. And the healthcare system can't cope with too quick change, because you can't always update your guidelines and implementations every month. Technology will develop much faster than you can pour that into practice. So you need to have a proper thinking what is really something you can set as a standard for a while, and where do you need to design for change. And that's also, again, a different way of thinking, because that you are not locking yourself in. The healthcare system is already locked in too many proprietary formats and company solutions and so on. How to open that you enable change and then can also adapt quicker the guidelines, the Leitplanken, to move forward. I think that's, again, something to consider.
Mm-hmm. Thank you. Shannon, last note.
Yeah, I think, I've talked about several examples where our aim is at regulatory convergence at the global level. And to go back to my initial opening comment, we're really interested in that early regulator-to-regulator engagement and public engagement on approaching innovation and regulation of new technologies.
Thank you. Thank you so much. I now let you take some air. We are going into lunch break. At 1 p.m. we meet here again to hear the visionary keynote of Sumbul Desai from Apple, and then hit the finish line with the presentation of the conference outcomes and our concluding discussion with the Federal Minister Karl Lauterbach. So have a nice last break and enjoy the last chance of networking. Thank you very much to our panelists. Thanks for being here.
So let's go through the project.
Oh. Cool.
That's not it.
Yay. There we go.
All right. You know, they pay me for that. I'm a pathologist. You know, I got to look at things and describe it, so there you go. There's the top left arrow pointing to the pre-competitive space. Those are the people that got together. First project. The group, composed of, I think, 7 people, came up with the idea of a federated platform. Now, that sounds a little bit strange because a platform is usually unified, but in this case, it was federated over multiple different sites where the data and the models would locate and would not move. Now, the use case that they discussed was, interestingly, for cancer care, although this was not the data against cancer session, but you see that problem is highly prevalent. 2 or 3 things that I want to point out here on this beautiful illustration done by Manuel, by the way, our graphic recorder, and all of these will be available on the website later on, is look at that beautiful paper plane there that will definitely cross the Atlantic. It is a pilot model, and I hope we can definitely move forward with that. So briefly, to build a foundational model that can work in a federated platform was the idea to explore that from a regulatory perspective. We move on to the second project on the top right. I think there were many different discussions about what that toolbox, in this case a regulatory toolbox, a political, a legal, and a technological toolbox would entail. Now, in this streamlined data access project, the key element that group explored was that there should be a regulatory stakeholder council. You see some of the constituents of that council to understand who should actually govern these tools that we're trying to develop, which I think is definitely an abstract sort of meta-level portrayal, but it clearly outlines that this came from the community as a concrete starting point to have basically a group of thought leaders, multi-stakeholders, to address some of these questions too. We get very practical on the bottom row. The bottom left, probably, I think, the most concrete table, in this case called a regulatory AI fact sheet. Think about it like an excerpt from a product description that clearly outlines in terms of describing what does the model do, in what population, for what purpose, and why, and what is the intended use, the indication of use, etc. This would be a tool where developers or those who haven't built the model can quickly assess what is the model intended to do and assess risks and benefits instantaneously. That could be a rubric that could be handed to a regulator for review, for regulatory review, to account for the various purposes, and then be delivered to the field as a concrete downloadable PDF or compendium so that AI developers can fill in the table to understand whether or where their risks lie. The last project, which tackled an interesting combination of a use case and one of the issues that we discussed in the very first panel discussion, which was trust. In this case, the tool would be an AI tool with the aim to prevent skin cancer, but exploring what that would look like if it is AI-powered or not in 2 different patient populations, and exploring from a regulatory perspective what that would entail. This would give regulators and developers the idea of what are barriers for and against trust for an AI in a purpose or in a use case like that. Ultimately, all these 4 models were also discussed against the commercial background to ultimately say, yes, these may all, for example, foreshorten innovation time or regulatory review time. So all of these fit into the large portfolio of regulatory science. They all were, of course, since the title of the session was Regulatory Science for AI, definitely on point. So that is the quick summary of the first session. And with that, I hand it over to Katharina Ladewig and Professor Halleck. Thank you. Thank you.
Thank you very much, Joe. Much appreciated indeed. It's wonderful to be here today with Macaholic, my co-moderator for the workshop number 2, Data Against Cancer. And we've seen already on the very first workshop, cancer featured very heavily. And so that's certainly a space where transatlantic cooperation is needed, is mandated. And so we followed a very similar format to what Joe's workshop followed. So we had a very short 2-hour ideation, design thinking session. I mean, I've never done ideation and design thinking in 2 hours alone. Usually it takes 2 full days to come up with ideas, rank them, prioritize them, and then develop ideas, fill in the canvas, focus it all together, and come up with a project at the very end. So I think the very first thing we should do is put a big round of applause together for everyone who participated. So put your hands together. Well done. The session Data Against Cancer can be really well summarized in this question: how will my data help me and others? Because data sharing should be bringing tangible benefits to the patient who is sharing that data, and we've heard that over the last 48 hours a lot, but it should also be bringing something to the community. And altruistic reasons for sharing your data are actually quite prevalent. Many patients would like to share their data to impact others and to help others as well. The very first project that is on the middle, to follow Joe's descriptive way here, so we're top in the middle now, the Cancer Genome Tracker was a very fascinating idea that came out of one of the projects. It already has 2 anchor institutions that would like to develop that project. So Harvard Medical School and the Charité are going to build a connected data-like ecosystem. They will look at the genomic data that is now available for many, although not all, cancer patients, in order to look at particularly metastatic prostate cancer.
And so this might help to identify patients that have, for example, refractory cancer, and look for novel treatments and resistance mechanisms. The next project was an interesting idea coming out of the registry. So we have different registries in Germany and in the US. The SEER database is used by many of us to look for features of survival, for example, in selected cancers. And so the question was, well, can we combine data sets from the 2 registries, the US and the German state-based registries, and learn from it. And there was a discussion how we can actually transfer. I know from experience that sometimes transferring data from Germany to the US is not as easy as extracting data the other way around. But in any case, this comparative project has a very precise and good purpose, namely to compare cancers that have a distinct outcome in the US and Germany. It's not always the case that the US data are better or the German data are better. It actually changes from indication to indication, and some with a couple of surprises. And it would be very good to learn which is the reason, what are the reasons why, say, a specific cancer type in the US has a better survival and outcome as opposed to Germany. And this is what this project is meant to be.
In this project, there was also a lot of discussion at the table. Do we have the same understanding of the data? Do we follow the same standards? Don't we? Do we have the same metadata or not? So another project, and now moving away from we're putting all the data in one pot and we're sharing it, is now looking at data in a similar style, similar structure, similar format, but using a federated learning approach. So the data doesn't move. It's being analyzed locally, and here we have a collaboration between a US cancer center, which could be the Dana-Farber Cancer Institute, and the National Cancer Network here in Germany. The focus here would be to use the ISO International Patient Summary. I hope I did get that correct this time, to use that and extend that data set for oncology purposes, and then use that to map an OMOP-based international patient summary in order to do this federated learning study.
And this project will be applied or can be applied within the German structures that we have, as compared to, for example, the Dana-Farber Cancer Institute or the NIH, where we have in Germany the NCT-based data set in the German network, or certain specific problems like non-small cell lung cancer, where both institutions have strong databases, and then combine those again for looking for rare causes of resistance and refractoriness. The next project is, again, quite different. It basically comes from the idea of using data sets for prevention. And you already have learned from the last presentation that there is a lot of artificial intelligence used now to recognize skin cancer. And yet, I know from training in this field, it's very different if you speak a different language. So the AI sets that are learned in English are not applicable in German. By the way, one of the reasons why German AI has sometimes problems to be implemented, because there's a semantic problem. And also, when it comes to outcome, do we report those outcomes in the advice given to the patients or in the analysis of the data in a similar or identical way? And there is good projects on both sides of the ocean on the preventive detection of early skin cancer by artificial intelligence. And this project will actually tackle this and create harmonized consensus data sets or understanding of the data in a very, very well-described project.
Yes, and then the very last project was a really fascinating project because it's something we can do now. It sounds very, very simple, but it should be done. It has to be done, and it's a project. Very good takeaway from the session here. The project was actually called Consent Now. It was really good that the team came up with that. And the aim here would be to take the learnings that we have in Germany. We call it from broad consent forms, patients providing broad consent, and creating transatlantic versions of that, of the patient consent form, as well as mapping the hurdles along the way of which consent do we need, legal frameworks, etc. pp. Have a standardized data flow is what we're aiming for in the end, that is GDPR compliant. And the team has already identified 2 or 3 cancer centers, both in Germany and in the US, where they would like to try that out and run the project in order to improve the immunotherapy in rare cancers. So a big well done to everyone. Congratulations.
Thank you very much, everyone.
Thank you so much, Katarina. Thank you so much, Michael. So with these results of the workshops now being reported, I hope that you're able to see the full picture of the conference. And congratulations to you and to everyone who was involved, because we heard at the beginning of the conference, this is almost like an inverted one. You don't bring your results, you bring your problems. We co-develop the solutions here. And congratulations on doing something which has addressed all the important questions as such an actionable result. So congratulations.
It is, and the Federal Ministry put a lot of effort into this conference. It actually was the Federal Minister himself who deeply wanted to make this international transatlantic exchange happen. So we are curious to hear how he reflects on the outcomes of the conference so far and lead us into our last panel discussion. Welcome again, the Federal Minister for Health, Karl Lauterbach, and Joe Lennertz.
Minister, we would love to hand over the results of the conference, of the workshops, for you to peruse and take into action. So what you've seen on slide now, this is the thing that you will be taking in-house probably and working with your colleagues in the Ministry of Health.
Well, thank you so much. I will take this in-house, not probably, but certainly. And again, we are very keen to derive specific recommendations and also, where possible, legal action from the recommendations. I have followed the work very closely. We entered this meeting with very high expectations, but these expectations were over-fulfilled. So it's really wonderful, and what I like most is that the results are tangible, real results. So thank you for all the participants in the groups, and I'm looking forward. This is a task for us, but we will live up to this task, and we have a very good team. So even independent from the ministers, the team we will be able to make the best out of this.
Thank you very much. We might need a little photo moment. Can we take a picture of this, or have you taken a picture? Yeah, you there? Okay. Maybe you can stand together a bit more, and then we take a nice picture of this moment.
Move away from the podium there.
Yeah.
I think a key moment of the conference. Yeah, maybe in front, that would be nice. Thank you. And as most of the panels, wow, there are a lot of phones up in the air. As most of our last panelists are already on stage, I'd like I'd like to ask, yeah, you can take a seat, please. Your names are marked on the seats. Just come around, please. And I'd like to ask our final panelist on stage is Hajo Krömer, the CEO of the Charité Berlin. Welcome.
Welcome.
So I'd like this to be more of a reflection of a few summarizing questions for this conference. Thank you for joining us to talk about how we can move towards better transatlantic health data use. And what do you think, how will data-driven healthcare look like in the future? Maybe Minister Lauterbach, you can start. And then...
Well, I do think that we will have much more data available because we are simply gathering data at an exponential speed increase, and I also think it will be easier to combine data from data sets that were not meant to be connected initially. Because with the science of large language models, it will become ever easier to basically make up for matters that in the past were technical matters of interoperability, to, let's say, bring this data together with intuitive ways of, let's say, changing the data set a little bit. So therefore, I think we will have way more data available, and connecting data will become easier. That is how I envision the future. And therefore, legislation and proper rules and trust and also good use cases and all of this will become more important. In essence, and this may not surprise anyone who listens to a politician, I think that politics will become more important in comparison to some of the technology issues in the future, because it's a completely open question if we are able to derive the best out of the data and move forward quickly, or if we exaggerate the risks and therefore are timid and leave behind the very patients that depend on the research that is not done because we were not daring enough. So that is how I think about it.
Michael, do you agree?
Yes, I fully agree. I expect actually that we now take action, and we should really make clear that we have a starting point where we are lagging behind many, many other European and other countries in terms of handling the healthcare data in forms of digitalization of the healthcare system. So we are not number one, not number two. We are in the end of the field, and we have to move out of this. And I'm saying this because we need to give the progress of the current medicine to our patients, and at the same time also, as a country of technological innovation, to finally grip the opportunity to create innovations and novelty and novel products in this field. And for this, we need to work with the data. You have seen from the beautiful example of Apple just a few seconds ago what we can achieve. And I'm deeply convinced that the European landscape and Germany are able to be competitors in this field and not only consumers. And this is why I think it's extremely important to take our hands together, bring our act together to actively shape the landscape of digital medicine.
Katharina, how can we get on top of this movement? Can you share some examples of concrete use cases where already today data-driven applications improve patient care in your institution?
Well, as you know, the Robert Koch Institute is not really involved in patient care on a day-to-day level. We are more concerned with the public health aspect of care. But one concrete example, we actually saw it yesterday on stage here as well. Yesterday, the intensive care, the Divi register was presented on stage as one of the examples. And that really, and it saved lives. You know, during the pandemic, being able to say we have that many beds available as inoperable because we have the staff available to operate the beds, and then knowing how many patients we have there on every single day, and what's their perspective when they move, helped us to utilize the resource of intensive care units and the beds much more efficiently. And so that is something that in my eyes, is important. And that is what we should keep in mind. Whatever solution we develop, it's about saving lives, improving patient health.
Hayo, can you maybe add to this, and then we get the US perspective from Joe?
Yeah, well, I think we're talking a lot about the technical options we have, which are the driving force behind the entire area. I personally think that, at least in our country, there are other driving forces, like a simple medical need. If you look at the specific German situation, due to demography, within the next 10 years, we'll lose something like 25% of our entire medical workforce. So we don't have a real chance, beside digitalization, to simply cope with that. And I think the conference here, in a real ideal manner, worked out prerequisites for fighting this, or for tackling these issues. There are several legs, like you have, of course, to have the financial resources. You have to have the real legal frame. There was a lot about that, which was really a hindrance in our country for a long time. I think there's no choice out of digitalization in our healthcare system, so it'll come.
Mm-hmm. And you talked about, or you worked on the legal issues in your workshop, Joe. Can you give us the US perspective on this?
Sure, happy to. I think the driving force for the digitalization shouldn't be the lack of a workforce, but that we free up our time to spend more face time with the patient. I think that is really the potential. That's a value proposition that's largely ignored. So a FaceTime one-on-one with a well-informed physician and a well-informed patient is extremely outranking any of the individual use cases that I can give you as brief examples. There's also a very practical thing, which is the one-to-many and many-to-one example. So an example that I mentioned yesterday is breast cancer. Breast cancer is one of the most common cancers, and we roughly know at least for 3 to 5 therapy lines how to treat it. But when certain things occur, and those are minute, suddenly things change. So you look at a breast cancer and suddenly you see that the patient is 14 years old. And then you think, oh, well, what do the guidelines say about that? Then you keep looking in the medical record and you find the 14-year-old girl is pregnant as well. And then we do genotyping and you find that there's a rare, previously unreported BRCA1 mutation, which is a very rare form of a genetic variant in that breast cancer. And you really haven't seen a case like that before. And with the integrated data, we literally built just a SQL query on top of that. We press an F button, and it pulls up all the other patients that we have access to, speaking about data utilization. And you see how other patients fitting that specific profile were treated, and you can make an informed treatment decision. So that's just one example where suddenly out of many, many things where we know what to do, just 3 features break it down to make it a very rare, unique case where many people are really hindered in making informed decisions because of a lack of data. So in other words, I think the prospective state of data utilization currently outranks the state of differentiation of what we can do.
Yeah.
I wanted to actually stress this point. I think the point also works for science. For example, we know that some drivers for diseases are extremely strong. For example, for Alzheimer's disease, the ApoE4 allelic variant, if you have 2 copies, then the likelihood of deriving Alzheimer's disease in your lifetime basically just depends on how old you get, but it approaches 100% almost if you are getting very old. But there is a small group of patients who will not develop the disease and will not come close to the disease. And we do not really know what protects them. And if you have large databases of carriers and have the small groups that never develop the disease, then we can basically derive from these rare cases the protecting genomic background or lifestyle measure, as a matter of fact. And therefore, it works for individual patients, but it also works in research. But it can only work if you can basically see the small example where the disease does not break through. from a huge database, and for example, in a rare patient, the cases that have been dealt with so far already, where you then may have a good way to deal with it. So that's, Joe made a very good point.
And that's very good examples already and answers to the question if transatlantic data sharing is optional or an integral part of future health data ecosystems. And I'd like to integrate more examples from the other ones. So how would you reflect on that?
Well, I would judge that it's certainly an absolutely integral part, because there are kind of features of both systems which may add to each other. I mean, Germany, in essence, has a widespread system of healthcare where many data are available over an entire population, which could be shared transatlantic and then maybe analyzed by certain AI approaches, which are not that pronounced in our country. So I think it's something like a must to have this partnership.
Mm-hmm. Katharina?
I think we can also have a public use case, health use case for that. Data sharing is not just important for individual patients. It's also, the last pandemic showed us that data sharing worldwide, as much as possible, a change in knowledge, and sometimes also we weren't able to exchange all the data, really helped us and to find answers quicker at national level. And many other countries also looked at Germany and what are the Germans doing, by the way, with this? You know, how are the Germans doing it? And it's not always transportable one-on-one from one national context to another. So you do need data to then model it into your own context. And I think the minister wanted to just add to that.
Yeah, no, yeah. Oh, yeah. You made a very good point. I have nothing to say that you haven't said already. So in that sense, it's a very important point. We have so many new opportunities. It is just our responsibility to use these chances. Simply put, when the pandemic hit, basically, it was a little bit too early to make the best potential use out of a mechanism like AlphaFold. But in the future, when a new pandemic will come up, we will be much quicker to basically derive proteins that will block certain, let's say, parts of the virus and will derive from the proteins the code that basically encodes these proteins. So we will go from code to protein, from protein to code, and the other way around. We'll become ever better with new methods like AlphaFold becoming better by the day, as a matter of fact. So I think in the future, we will have a completely different way of, let's say, creating medicine. We will way more rely on synthetic knowledge, which is derived from databases and artificial intelligence systems like AlphaFold or many others.
But already during the pandemic, we went quite quick, right? I mean, it was much quicker than we expected.
Much quicker, but we will be even quicker in the future.
Yeah, so Michael, last one, how would you, what would you say, or what kind of example would you give how patients or providers would experience the benefits of transatlantic cooperation?
I will give you two examples, one from research and one more on the, let's say, human resources and the use in medicine. So as being a researcher on leukemia and cancer, what we do now is to describe cancers in a much more detailed level every single day. So from genomics to the methylation, to the proteins, the translational machinery, and finally with the microenvironment, and all this on a single cell level. So you have a huge amount of data. Actually generating the data in some of the research projects is extremely costly per patient. So you have terabytes of data per patient, and now you wish to understand what are the elements in the microenvironment, in the genomic layers, in the proteins of the cells, and not only the cancer cells, but the microenvironmental cells, to drive the evolution of cancer, either the onset or the resistance. Highly complex, highly costly, and because it's so costly, these data are extremely precious. Yeah. So sharing data between different institutions in the US and Germany, which are often amongst the leading institutions in the world, is not only making sense, it's a necessity, because we cannot duplicate research all the time on the different continents. It's a nonsense. And let me come, so this is a research example, and I think it's a must to share data if you generate such complex data. The other thing is, coming back to where we do it and why we do it. So I would only hope that developing digital tools in medicine will serve the patient and the physician to gain more time for real interaction and empathy with the patient, rather than distracting us and sitting in front of the computer and not even looking at the patient anymore. So I think it's really important that we define in medicine, together with the patients, the good use, and that is freeing time for speaking and talking to the patient and listening to them.
Yeah, Kai, you wanted to add?
I think this, we will also be in competition. Yesterday, for example, we had this meeting with the Chinese delegation, and the Chinese Vice Minister of Health is extremely knowledgeable about these issues. So we were speaking about, he's an immunologist, and Chinese cancer research is becoming more competitive by the day. So you have 2.8 million new cancer cases there per year. The AI developments are very impressive. They are very impressive. They know exactly how to do omics data, how to do single-cell research. They do the coding. So ultimately, they will have a database which is way beyond what a single country like Germany could ever master. You have, roughly speaking, 20 times to 50 times as many cases. You have free access to the data, and you have a fairly, let's say, liberal way of dealing with this data, to put it carefully. So if we do not want to lag behind, we need to team up transatlantically quite clearly and within Europe. And the meeting today, in my opinion, is one of the occasions to basically create an environment of trust where we can share the data that we must share in order to be competitive.
I think what Karl just said is also an economical question. If you look how the Chinese transfer these data, for example, into the health insurance business, it's pretty clear that you will have an economic competition in due course. And they will certainly enter Europe, and we have to put something against that.
So speaking of costly data and competition, how can we enable health data use in Germany to create a more competitive research and innovative environment? So you might start.
I mean, there are several ways. So in the US, data is collected at the state level, reported centrally. And there's one thing that became pretty clear. Some databases need to reflect certain strata of population in completely different ways. For example, if you want to create tools or medication or devices that affect Native Americans, you have to reflect that very small population at a much increased level. So a biased, in that case, with a good intention population is extremely important. Now, if you consider the German population, that is a different beast. If you develop an algorithm on the one side, you can test and validate it on a data set of the other side and vice versa. I think that is a diversity or an attack on diversity in a way that we can't do just in one country. I think Professor Halleck mentioned the example of semantic issues, for large language models. If you look at image standards, there's an international DICOM standard, for example, for radiology images, but the metadata attached to that are not by any means standardized in an international language format. Just another quick example. There's a catalog of streets, the names of streets, just as a simple example. That's over 290 pages long, that was recently released from ONC. We have huge harmonization issues, and if we harmonize only in one country, it will certainly be beautiful and it will work for one country, but that will certainly not work in Europe, and it will certainly not work transatlantic. So those are some of the practical examples of what data sharing practices will look like. And doing that transatlantically will get us much further, much quicker.
Okay, we're going deeper into this in a moment, but Katharina, maybe you'd like to add on how to create a more competitive environment here.
I would like to take the next level up. Just looking at Germany, we are here to foster transatlantic collaborations between Germany and the US, but Germany is obviously a member state of the EU, and I think we also benefit greatly from many of the European efforts in that space. And we do have the European Health Data Space coming along. There was a major piece of legislation. It will now be translated into the German legislation. And so many of these things that are applicable to the discussion today that we are having here are also applicable at the European level. And I think there is great efforts already being undertaken of harmonizing legislations there, although we do have quite some way to go. If I'm looking at Joe, who wants to comment on that.
Yeah, well, let's dive deeper into this. So you tipped the data quality issue, the standardization, the legislation issues. So what are the current challenges in cross-institutional health data use, and especially transatlantic data use? Maybe start with the institutional first, with you, Michael.
Creating incentives, you mean? Or
Well, yeah, current challenges in whole, but creating incentives is definitely one of these.
Well, it's actually a tough question in a way, because we have a couple of hurdles, but let me give you a couple of thoughts how we can overcome some of the hurdles. So first of all, in Germany, we don't have good electronic data records from patients that are done in a harmonized way. We have a lot of separate silos, so therefore, if we want to combine and analyze data, we are lagging behind a consortia in the US that have these data and document only with one system. So harmonization is a big thing. Interoperability between the systems is a big thing. And I have a, let's say, maybe not really politically correct recommendation here. There's one space where you always get data, and that's when it comes to reimbursement. So that is where data stream in like crazy, very fast. And all the rest is much more difficult. So to link reimbursement to data providers, to data provision, for research or other purposes would be a very smart move to actually create a bit more incentive to get the data, the healthcare data records also usable for research. The other thing I think in Germany, and that's a personal impression from projects that I have created to work, we need to have, at least for the German side, a much more pragmatism. So we should talk not so long or less and do more. And that means implement things that really are working in practice. And I say this because in my personal opinion, when you work with academic institutions in the United States, what I always admire is they have more pragmatism to get things done, in particular in the translational space. And that is, I think, the second big thing we should not only learn, but simply do and do it faster.
Mm-hmm. I saw you not agreeing with everything Michael said.
No, not a disagreement. We agree 99% of the time. But a point which I, let's say, may be mistaken, but I'm personally, for hobby reasons, I'm very much interested in how AI develops and what is, let's say, what is most likely going to happen. I personally think that's a problem of, let's say, making data available, getting data, and so will change drastically. To bring an example, for example, the language problem, Germans have used a different terminology for pathology and so forth. Large language models will learn what we typically use instead of the American term and will ultimately fully understand what is the best way to, let's say, express a particular feature in a cell in the languages that are needed. So we do not need to explain what is a German term, what is a US term, what is a SNOMED term, and so forth, but the system will learn what the terms are. So therefore, the translation will become much better, and therefore will make databases connectable that were not meant to be connected. And to make a long story short, we do not need the complicated, let's say, interoperability semantic issue to the degree that we now need it. So that will change. Number two, many data will simply be derived from our exchange with the patient. So therefore, this dichotomy is spending time with the patient and basically doing administrative work. That will collapse to some degrees, and because while I speak with the patient, The new systems will derive the data from listening to me, as a matter of fact. So therefore, me spending patient time at the same time generates data in a structured way. And these are completely different ways of collecting data, basically while we are in an interaction, and making data comparable, or let's say condensing databases, or let's say combining them and so forth, without us having to do. It may be possible that we do not exactly know how it works. We will have an alignment problem on both levels. Getting data, we will not exactly know how the translation works, so we will have an alignment problem there. And we will also have a problem understanding how the data were gathered from our talk with the patient, for example. So no alignment there is possible, potentially. But since we can correlate and evaluate analytically how well it is working, we do not need the alignment in particular. So this is, let's say, not a disagreement, but I'm way more optimistic with respect to, let's say, the availability and also the interoperability of data, also transatlantically.
So agreeing with all of what's been said, how do we achieve all of this? I mean, we tipped on the data quality issue already. Do we have enough data in the right quality to set up all these massive databases to train AI?
I mean, the first starting point is usually in research, so we can translate and address a healthcare need. That's the first part. The healthcare need is sitting virtually, let's say it in the lab, but ultimately it's the care delivery that we need to attack. To go there, we have to have clear value propositions. So for example, an average lung cancer patient takes from first symptom to actual, let's call it molecular targeted therapy, 4 to 5 months. We have to treat first to keep up with the tumor growth that it took from the time of last imaging until the drug was actually prescribed and taken in. That paradigm has to change so that people get treated within very few days. Now, for payers, that is a huge incentive because it is not an odyssey that stops at 5 different subspecialists that all requires interactions and payment structures, but it requires the very careful functional and administrative design of care pathways, and those should get financial incentives behind it, extra pays for quick and reliable, high-quality diagnosis. In contrast, not every case can be applied to such a coherent care pathway, so some patients still need to meander. Some diseases are incredibly complex, but that is not the case for an average person. So the incentive has to be created, including economic incentives, of course, but they should all be tied in one coherent, disease-specific care pathway proposition. And I think that is a way that has worked, at least with many of the private and governmental insurers in the United States, especially for new technologies. And everyone is thinking about how to create incentives for AI, but they have to live in clinical care, and they shouldn't be financed through research. That should be part of the routine care that every patient can benefit from. And if that value proposition is not great, then we probably need to go back to the research lab and figure out what went wrong.
Yeah, right. I see you nodding, Hayo, from a practical point of view.
I think it's a completely interesting point, and comes a bit back to what Michael Halleck said in terms of attitude. Right? You just talked about the adjustment towards new ways of dealing with patients in the United States, which is kind of really completely different from what we currently can do in this country, and which we admire always a bit in the US. And if we are at attitude, there's another thing which has to be talked about, which is the way, not only in terms of science or in terms of treatment, but in terms of legal action around data. So in there we are at the data protection thing. And as you know, the entire European community has the identical legal frame around data protection, yet they are completely different in terms of using them. And I think that's quite an important point to talk about that. And the only way to do that, which our current government does, is convincing the population that we should have the same attitude to data use and data protection like all the other countries around us. So there's a big kind of non-scientific legal difference in dealing with these issues.
Maybe one comment. I do not think that the US payer system.
No. We agree on that.
The payer system is not to admire in the US. The payer system is like a gigantic cell with many pathways that no one actually understands. Yeah. So I don't think Germany should move there. If that came across, that was wrong. I think
don't worry.
Good. Thank you. I just wanted to clarify that because I think
that was not
the question is why can't we have in a simpler payer system a similarly effective incentive structure? I think that is the key question.
Yeah, and that's a question whether you get a kind of hybrid, getting the good things out of both systems.
And I think the reason, and I think that is actually a very big high five to the entire health ministry, right? We're talking to the same ministry that does innovative technologies and routine care delivery, including care documentation and everything. This is not, right now, we're in a pre-competitive space, but with a keen eye on optimizing care.
Katarina, I saw you nodding as well. You might jump in.
I can just agree with everything that's been said. It's been fascinating to watch you two have a conversation here on the panel. To maybe come back to the data protection point that Tayo Krömer made. The problem that we have indeed is the different interpretation of this united legislation that we have, and we need to move away from that. We need to have one way of interpreting it, and something that a lot of colleagues always say, and that really only works in German. So I'm going to say it in German first, and I'm going to translate it in English. It's we need to move from Datenschutz to Datennutz whilst maintaining data safety. So it's moving from just protecting it to using it, but maintaining data safety. And I think that's a very, very important element. And something that was said yesterday, and I think it was the very first panel, it was also, we all need to go out there as we are collectively assembled here today and then tell that story. Data privacy is important, protecting is important, but it doesn't mean that we cannot use it. And so that's a very, very important point that was made there earlier.
I think there was a point that Lawrence made on one of the panels today that we should shift the discussion from data access to data use. So explain to the patients and explain to the citizens why we are using data and not which data we want to access, right? That might be, we discussed a lot of a cultural change as well, and that would refer to what Michael said, the pragmatism. Is that one of the things we need to focus on more?
Yeah. If I can be very short in one statement, because I think it needs to be brought across, and I also followed Elena Buick's talk yesterday, and I think that's a bit what she wanted to emphasize. We don't really protect data professionally in Germany. We neglect data. You cannot say that data that are in paper versions in a cellar of a hospital are safe. Mm-hmm. You can also not say that we didn't have break-ins into our healthcare data sets in small hospitals because they are usually unprofessionally protected. So data protection in Germany is not professional. It needs to be improved. But to neglect data and then assume that you protect them somehow is a total misconception. Yeah. So basically, we have to move away from neglecting the data that we have to use of the data while protecting them and generate safety. That's a combination of skills that we don't have and need to develop.
Huh. First of all, things are changing, and we just now are introducing a law where also the data protection rules are changing. This is the biggest change in data protection legislation for 20 years that we are now dealing with in the cabinet, which will basically come up with a more comprehensive assessment how data should be protected, taken into consideration ethical issues, scientific issues, what is lost in terms of lives that could be saved if the data are not used, and so forth. And there's also currently a veto power from, let's say, data protection agencies that override all potential other reasons. For example, if the data protection is not acceptable, even if 5 million of people would die, that would not count. You have 5 million people dying, and here you have a safety issue, then the safety issue trumps the 5 million people dying. And this is obviously not a good system, so we change it as we speak, as a matter of fact, that law is already in the cabinet, and it's the biggest change in how we look at data. In a nutshell, the idea is not using data that are there is also killing people, and we don't want this. So we make a big change here, but it will not be easy because, for example, I give many interviews about the conference and how we are doing and so forth, all fine. But what I typically get asked is basically, well, are the data then also available to the pharmaceutical industry? And this is almost in the tone that if you are asking, are the data soon also available to the drug and to let's say drug cartels in Mexico also. So we have a feeling that something is wrong if pharmaceutical companies are using this data. But if we want to have research, meaningful research in Europe and in Germany, and the data are, let's say, used in a way that you cannot identify the people who spend this data, then we will all benefit, as a matter of fact. And we will have a culture war about this, and let's say a small group will be very vocal against it. But the government, including the chancellor, but the government in total, is fully determined to change the rules here so that we will have a much better availability of data and use them in an ethically responsible and scientifically exciting way.
Mm-hmm. Thank you. Joe?
I didn't think we would talk about drug cartels, but that's a good example. One thing about data protection that I wanted to reiterate, just in case someone was asleep earlier, I know that happens sometimes, or you were on your phone. There's one very concrete thing everyone in the room can do when we write our papers, and that is do not protect your data from being meaningful to the regulators. You can put an extra paragraph in every discussion outlining the meaning of your findings from a regulatory science perspective. That is extremely valuable. That is making the data accessible to the next instance in that development towards care. The people in the ministry read the papers. If you explain it in the proper regulatory terms, your study will have more impact, not maybe to your primary part, but that is a very important call to action. So if you share that with your PhD student and postdocs, maybe the paragraph needs a lot more revisions and maybe a reviewer may not get it, but you really have to do that part because that's also protecting your data from access by the person that you're effectively addressing if you can't roll out AI. So one task, homework, check.
That's a very good outcome of this conference, is advice like this. But as we were speaking of the patients and the public and the citizens, what can we do to bring the public on board with the discussions around health data use and elucidate its benefits? I mean, we haven't touched the issue that people are sharing data all day on Meta, on Google, on wherever. And we have so many problems to convince them to share their data and their health data. So how can we bring the public to share more? Ayo.
Well, I think in our country, the entire discussion around data protection was mainly dominated by very few people who had a very strong opinion on the entire issue and really governed the discussion. From my point of view, with the background of the new legal situation as outlined by the minister, we have a slow but constant change, and that is in particular driven by the fact that the patients get more and more outspoken to this issue and really argue that they are protected from being better treated by not using the data in our country. And so I think there is a shift which needs to be really supported by a public discussion about what happens now. And this public discussion should not be restricted to the dangers of sharing data, but to the options like we had in this round. And I think we need to set a new stage of discussion and then I'm pretty sure that we'll get there.
Mm-hmm. Michael?
I can partially echo that and therefore emphasize we need to go out and explain over and over and over again because it's a fundamental change. I think the law that is implemented by the current government and the minister is really, really important. catch up and to actually overcome our situation in Germany, which is, as I said, not competitive and not good for the patients. But we need to explain this to the public. We need to explain it in lay terms, why this is important, why there are benefits for individual patients and for our society, and convince the public that this is needed. And number two, my experience is patients that have experienced the benefit of sharing data or are oriented towards novel research results can really help us and are actively helping us to make it understandable why this is so badly needed. So this is all about communication, and this is finally why conferences like this are so important, because they explain the matter.
It's nice that you mentioned the conference, because the question here is, where do we go and how do we communicate? There were several examples for this on this stage. Katarina, maybe you can add some.
I just wanted to add on to what Michael Halleck said. I think us talking about this in this forum is very, very important, and it helps us to wrap our own minds around what needs to be done to move this forward. For patients, it's potentially slightly different, because these are very abstract discussions also. Even if we're talking technical terms and talking standards, I don't think the patient cares about what standard we're using as long as we're using a standard. What the patient cares about is finding out in a language that they understand, what does it mean for them? And so one homework, if I may add a second homework that for all of us, is to think about our research that we do in lay language, to explain it to the people on the street. And they are not dumb by no means, they are educated people. But try and bring them into your world for a while so they understand what it means if they pass on their data, they let you use the data. It means a lot to you as a researcher. You can move forward with your research, but then give it back to them and say that extra little sentence, and by the way, this is what it means for you. And then that part of the conversation should actually be 3/4 of the conversation you're having, where you're explaining it in the language that the patient understands, and it makes it meaningful to them why they are sharing their data. And that is how we will be changing also the culture of utilizing data in Germany.
Carl, that's actually what you are doing all the time and all day, explaining, trying to...
Right, yeah. But it works, as a matter of fact. It's my own experience, even as a minister, but before as well. If an idea, if the time for an idea has come, and the idea is it's, let's say, ethically tenable and scientifically clear idea, the more you explain it, the more likely it is that ultimately the majority of people will agree and it will move forward. So that's also, I think, what Hayo was saying, that we now see a time change in that respect, and we see a time change Zeitenwende in many fields of politics as of now, because this is not party politics, but we have basically neglected modernization in many fields, and the data sharing and also transatlantic data sharing and making data available to other countries, which we are also under an obligation. It is not fair that we only take the results of data out of countries where the data protection may be even minor in comparison to what we are doing, but we give back nothing. This is also internationally an obligation. We have to, where we can do so, we have to share vaccines and knowledge about vaccines. Where we have data, we should share data. So therefore, it's ethically necessary. And indeed, there is only a couple of countries that at the highest possible level can analyze and gather data on which, let's say, treatment depends worldwide. So, and we are part of this club. This brings us into a special responsibility as well, and this is why we have to move forward.
Mm-hmm. Sure.
Maybe one word of like a caution. Medicine as a field has not been prepared for an attack on their data by outside entities. And I mean that in terms of, it could be industry, it could be commercial endeavors, it could be just data breaches, it could be just hacking attempts, could be illegal things. Medicine by itself has such a, ancient history especially when it comes to IT infrastructure, that poses, of course, risks. So we have to address them proactively rather than sitting at the receiving end. If some giant creates something that then everyone uses and we are basically secondary users of that, it should be the field of medicine that drives care delivery. Similarly, what Professor Lauterbach just said, if other countries that have less stringent data protection, that will mean that all the models, all the things that we derive from that data might not be applicable to the German population. So then we have very safe data, but they're basically useless, and the models may not work. The care delivery mechanism is hindered by that safety. So neither extreme is good. So finding that balance is extremely important. So addressing it now in practical terms is, what we call data for health.
Mm-hmm. As we discussed a lot about the European health data space, I'd like to quickly integrate it into this point here. What is, from your perspective, from the US perspective, what is the US hoping for? What should it be? And then I'd like to integrate the rest of the panel.
Yeah, the European health data space is currently an abstract concept with many different rules colliding. So it's like a mind map of elements that we're trying to figure out. I believe Germany is in a very well-equipped position to drive that the design, the architecture, and what it can and cannot accomplish, and what it should and should not accomplish. From the US side, it is, in a way, a separate regulatory and a separate data infrastructure framework. But for some diseases, there's a clear need to validate models or tools on independent data sets. That's, I think, the interest. So the interest for the GDPR-induced cut of the US privacy shield, so there's no way of establishing that. Of course, with a big capitalistic enterprise, or you take the Federal Trade Commission, they will establish an exchange in the commercial sector, but that is not necessarily applicable to medicine or healthcare delivery. So I think that part is they want the data and they will get it one way or the other. And if they get the validation set outside of the European territory, that just means Europe as a whole would fall behind in terms of utilization of these new technologies. So that's a missed opportunity if we don't design it right so that it can be used in a supranational way.
Yeah.
And I think that's very, very, very key in the design of the European health data space.
I'd like to know the perspective of the big hospitals here. So what's the Charité hoping for?
Well, if we get this European health data space running, it will be a huge advantage for Europe, for sure. I mean, we've learned during the pandemic how even small countries like Israel with a well-organized system can profit from that. But, the European health data space, I think, always looks like a house with multiple apartments. And the apartments have to have roughly the same rules if the entire thing should work. And we're a bit away from that, to say that cautious.
Mm-hmm. Michael?
I would say that there's always in the two different continents things that work better on one side or the other. So it's not like we have to mimic everything that is done in the data space with data in the US because of our difference in the interpretation of personality rights. And I think it may be beneficial for American corporations and universities to be challenged by this and then create rules that have, let's say, a good European standard of privacy protection. That can be a selling argument, by the way, but it needs to be implemented in pragmatic ways. So pragmatic means really doable and not hindering research. That is something we can learn from Ms. Aja. Then in certain fields of research, and in cancer research is certainly so, we can give something because we are leading, and we can learn something because we are following. And this is what I would expect from a cooperation with my American colleagues.
Mm-hmm. Katharina, from the AI perspective, what are you hoping for the EHDS could be?
AI needs data, so I think that's a very short answer. Yeah. We're hoping for larger, better data sets that we can access more easily in a more standardized way. I think the beauty in the EHDS will be that the access is already within the framework, it's regulated within the framework, and there should be access, and it should be possible for any researcher within Europe to access similar data sets in all of the other countries in the same way. And so I'm very, very hopeful that once it comes live, we can access it, and then we do have the data on the population of Europeans, and it's coming back to Joe's point, the algorithms need to be trained on data that represents the population rather than on data from people from outside of Europe. And so I think that's a very big benefit of the EHDS.
Yeah.
But I'm personally reasonably optimistic about the European health data space. First of all, the Commission really interacts with the countries very closely, reliably, and technically on a high level. So I think ultimately for secondary data use, a good solution will be found. It will ultimately most likely end up to be an opt-out solution, maybe somewhat dissimilar than the one we are currently following. But if there is, let's say, some space that countries can go about, let's say, dealing with the opt-out issue a little bit different from country to country, but if the data that are not opted out are available to everyone, that would be sufficient. So I would rather leave some, let's say, discretionary place for the countries in order to opt out for an individual, but then permit the data that are available for use for everyone. That would be wonderful. A problem which I see at the horizon, and I again apologize for making a technical point. It is, but the technical point here is that in the future, data which are anonymous data, where, for example, place of personal data have been removed, they will be much more easily to be re-identified with large language models, because large language models are so good of basically prompting around particular data sets that they are much better at identifying the source of the data. And this is a new problem, as a matter of fact. So therefore, some of the research institutes are now working at, let's say, deliberately bringing noise into the data. So then the data lose some of the, let's say, value in terms of, let's say, its characteristics, receiver operating characteristics. So the sensitivity and the specificity goes down a little bit, but the noise makes it more difficult for these models to re-identify the source. This is a technical problem. That is also, but it shows that, I mean, it was even within the discussion of the European health data space, such issues are now already discussed. So I think that is a very high quality discussion that is going on there, and we will ultimately see a good solution.
Yeah. Thank you so much for being at the conference. Even you, Carl, tried to attend the parts where you could come over, and most of you were here all the time. So I'd like to hear what you think, looking back on the conference, which stimuli or assignments will you take back to your work, Michael?
Well, I take back the atmosphere here. I was positively surprised about the atmosphere and this lively interaction of people that are really excited about the new tools in digital medicine. I think all of you, I would assume, are here for a greater benefit of this society. Basically, it's all about creating health for everybody in a democratic society with the novel tools. And that to be orchestrated by a ministry in this fantastic atmosphere, I think was good to see and gives hope for the next few months.
Yes, I agree. Katharina?
I think I concur. The atmosphere was wonderful. So I'm going to take that with me, the enthusiasm to go on into the next couple of days and weeks and months and years ahead, and working together with the colleagues from the US and also from within Germany. I've met many new faces. That was really lovely to see that we weren't just having the same club as we usually do. And it was really, really lovely to see many new people on stage as well as in the audience and in the workshops. I will also take away a lot of the individual discussions that we had within the workshops and try and follow up on some of them to make sure that these projects are actually moving ahead. And, you know, hey, have you done that yet? Have you tried to move it ahead? Because you can make the best plans in the world. If you don't follow through, you know, nothing will come out of it. So that's been really wonderful. I will take a lot of what we did over the last 2 days and take it into the RKI, seeing what we can do, moving it maybe from data for health to data for public health next time for the next edition, because we obviously have a very, very strong focus on public health, and there was a lot being said for medical care and direct patient-to-patient relation, but public health is another very important element of health care.
Hajo, what do you take back to Charité?
Well, usually the small part I've seen, usually at these type of conferences, you would have a situation where very specialized people, either from science or from clinics, discuss very special problems with each other. And in view of the entire turning point we currently see in Germany due to legislation, it was interesting to see a meeting which is kind of initiated by the ministry and draws such a large crowd to this particular problem, offering a new way of attacking this problem. So overall, I take out of this a very positive attitude to the problem, and I think there's a kind of hope in our country towards a solution of this long-lasting problem, which hasn't been there before.
Thank you. Joe?
First of all, I will go back to Mass General and I will report that this vibe in a conference where I met many, many new friends, and thank you for that, reminded me of the first couple of months of the pandemic response. That may not be known in Germany, but the whole world was watching how exquisitely and enormously science-driven and concrete and amazing the first, indeed, pandemic response was. Everyone was watching. And I had the same vibe here talking to everyone to say, you know, hey, we built this tool, look at this, and everyone was fully engaged and super enthusiastic. So I will report that back to Mass General and, you know, my bosses.
Thank you. Thank you very much. Kana, your dance is not to make closing remarks because we hear you later on, but maybe you can sum up like the discussion.
The bad news for my ministry is that there's a lot of work for the people working there. That is a clear message, I think. And I should also say there's a lot of work to be done by the Gematik. The Gematik, the agency which supports the ministry in making a lot of what we discuss available technically, but also regulation-wise. And I'm very pleased that Professor Deacon is here today, followed the meeting all the time, made contributions, so a lot of work is coming up for you as well. I do think that Joe put it in exactly the right term. We need the spirit of we must change something. And this is clearly the spirit that we do have in the cabinet, in our government. We really want to make a change, and for example, we will roll out the electronic. We will roll out the electronic recepts, the electronic prescriptions, the electronic prescription 1st of July. So this has been out there in announcements for 10 years, 10 years worth of announcements, and very soon we will roll it out. We will have another conference. We will meet in September. We will have another meeting here at the Robert Koch Institute in November. So this is ongoing work, and we will want to make it as quick and tangible as possible with your help and contributions.
Thank you very much. And in order to let you make your last contacts for today and for this conference, we leave you to a short 20 minutes last coffee break. So if you haven't met someone you need to really meet, then do this. Maybe the minister or anyone else. So thank you very much for the panel, and we see each other at 3 o'clock for the closing remarks. We await Deputy Chief of Mission of the US Embassy, Woodward Clark Price, and the minister again. Thank you so much.
Super.
Oh, that's so nice.
Welcome, everybody, to the closing of this beautiful conference.
Welcome back, everyone, and we hope you enjoyed a cold drink for this refreshing moment. Now, we're moving to the final moments of the conference, and we would like to invite you to this final session. The purpose of this conference was to move towards better transatlantic cooperation and collaboration, because both as countries and nations, Germany and the United States, can learn and benefit from each other and their different approaches to healthcare.
And the heads of our nations are here today to underline this need for a fruitful and cooperative future in medical science between our countries. And therefore, I'd like to hand over to the Deputy Chief of Mission of the US Embassy. Please welcome Woodward Clark Price.
First of all, Minister Lauterbach, it's a real honor to be with you here in this wonderful forum today. I do want to thank the Ministry of Health for hosting this conference, which is on a complex but really, really important theme. I also want to thank the experts from both sides of the Atlantic for their participation. It's crucial that we seize on the broad range of opportunities arising from data-driven improvements to health and society. The United States and Germany are renowned for their cutting-edge research and innovation. We are leaders in this field globally. Connecting our experts and data holds enormous potential. In recent years, though, the broader utilization of health data has advanced medical knowledge on an unprecedented scale. Life-saving treatments, vaccines, and policies have been made possible in record time thanks to health data sharing and research. Improved cross-border sharing of health data will open new opportunities for research and development, which in turn will translate to higher quality health care. The criticality of collaborative international research projects and research data sharing in biomedical and health research has been illustrated throughout the COVID-19 pandemic. One of the greatest accomplishments in modern medicine, and a great example of German-American cooperation and collaboration, was the development of vaccines against COVID-19. Working together against time, BioNTech and Pfizer co-developed the first COVID-19 vaccine, granted conditional approval for use in regions and countries around the globe. I was a recipient of one of those vaccines, and it perhaps saved my life. The two companies saw the potential of directing their research efforts to tackle this historic challenge and leverage their combined skill sets and experience to respond to the global health crisis. A crucial step in the process was the generation of the data required by regulatory authorities to assess the safety and effectiveness of the vaccine. I'm sure you remember when the vaccines were first invented, it took some 2 weeks to sequence the DNA, but it took months to get the regulatory approvals, which were based on that essential data. The United States and the EU must continue our cooperation on life-saving biomedical science and data sharing to make progress on global health challenges and achieve our global health research priorities. The 2023 G7 Health Ministers communication read, quote, "Strengthening the rapid sharing of public health data information available while ensuring the respect of relevant data protection rules is critical to rapidly identify and communicate risks and develop science-based approaches for effective public health responses." Both the United States and Europe are taking steps to harness the benefits of trusted health data. We need high-quality data, infrastructure, and governance to ensure that research innovations are turned into practice and don't just remain in the lab. The broader research community needs clear and consistent opportunities for use of health data in research. In the United States, the federal government is building a network to make it easier for health plans, providers, public health agencies, and patients to exchange health information. The Trusted Exchange Framework and Common Agreement, or TEFCA, will go live by the end of 2023, that is, in this year. TEFCA grew out of the 21st Century Cares Act, a law passed by Congress in 2016. that required HHS, Health and Human Services, to establish a framework and model for health information to be exchanged seamlessly nationwide. Practitioners have told us repeatedly how frustrating it is to be in a position where you know the data exists to help you make a better decision and you don't have access to it. We are all better off when our data is shared and when it is done so safely and equitably. As Dr. Arati Prabhakar, director of the White House Office of Science and Technology Policy says, quote, ultimately, we aim for the kind of deeper understanding that allows us to recognize the sources of diseases and start eliminating them. TEFCA will change how health unfolds and advance health equity in the United States. It will improve health outcomes for every American, irrespective of gender, sexual orientation, race, ethnicity, or even zip code. The United States, for our part, welcomes the proposal to create a European health data space. We share the goal of harnessing the benefits of trusted health data that can play an essential role in improving health outcomes and ensuring the development, authorization, and most importantly, deployment of safe and effective medical products. This is a priority in the United States. It is a priority for the G7 as well. It is also a priority for the TTC, the US-EU Trade and Technology Council, which has made such strides. At the December meeting of the TTC, we announced that we will work together on the exchange of healthcare information. The pandemic taught us that preventing and responding to global health emergencies cannot be the responsibility only of practitioners. As we witnessed, the pandemic was not just a health crisis. It was also a security crisis, an economic crisis, and a humanitarian crisis above all. Global health is of concern to all of government. We need streamlined, consistent, and secure access to quality health data in order to take advantage of our full potential to improve healthcare and boost research and innovation for EU member states, the United States, and the world. I applaud the efforts underway to ensure we succeed in achieving our global health goals, and this conference is such an important part of that. So thank you all for your contribution to these efforts, and I hope that you have a great conference going forward. Thank you so much.
Thank you. Thank you so much. Thank you so much. Thank you so much, Deputy Chief of Mission Woodward Clark-Price. It was an absolute honor to have you here for those words.
But the very last words, of course, belong to our minister, the German Federal Minister for Health, and that's Professor Dr. Karl Lauterbach again. Thank you very much for hosting this conference, and this is the very last words for you. Thank you.
Thank you, first of all, for these generous and very important words. And I could almost cut my own closing remarks by half by simply referring to you. So thank you so much. This was a very, very honest, very good to support. It was your sum up was as if you had been at the conference for 2 days. So thank you so much. Dear ladies and gentlemen, let me briefly sum up, very briefly. First of all, I think the conference definitely was a major success from what we had hoped to accomplish. I discussed the conference, the content, and what we have been able to discuss yesterday and last night, today in the cabinet, also with Chancellor Scholz, and I should say the German government in general, and Chancellor Scholz is fully engaged in the kind of time change that we want to create when it comes to, let's say, using data nationally and also internationally. And this is not what we want to do in terms of party politics, but it is something where we feel under an obligation that we must make this possible. We have lost so much time. Germany was a pioneer in the early 2000s in data collection, in electronic health record views and visions and so forth. But we have lost 15 to 20 years, and we are now trying to gain momentum, and we really want to make major investments here. So on behalf of the Chancellor, I would like to thank all of you, because we are currently in the process of making major laws, 3 laws, 1 law about, let's say, the electronic health record, opt-out version, data protection rules, and so forth. Number 2, secondary use, data use, basically a law which will make it possible that routine data that are collected in reimbursement issues, in registries, in treatment, in the electronic records, that these data will be available for research purposes, for scientists, but also for companies. But the data will not be provided to someone, but only the right to use the data will be provided. So the data will always stay with the government, as a matter of fact. And the 3rd law is the law where we modernize the agency which is responsible in Germany for making a lot of what we politically want technically possible, currently led by Professor Lark-Dieten, who is here, and we will also modernize this institute. So for what we want to do in Germany, the conference was of simply enormous value. We really learned a lot, and we learned it on time, because with these 3 laws, we are currently going through the cabinet. Number 2, the goal of the conference, and this was the goal that Joe Lennox and me, we agreed upon, is how do we make transatlantic exchange of data and common research possible? And this was a very focused conference. Many conferences on data sharing and AI spread on many issues, but they are not focused. This was a very focused meeting, and it focused on exactly that particular issue. And we have seen very important and impressive technical solutions. We have discussed the ethics of data sharing. We have discussed the necessity of data sharing, but we have also dealt with the promises of data sharing, in particular this last panel discussion which we had, and the results that were shown from the Barcamp groups. This showed the potential of what is in there. And I come back to this point in a moment. So therefore, it was a good meeting for us locally, nationally, but it was also a good meeting for the purpose which we intended to follow up on. I'm also pleased to say that this was a meeting where there was a lot of interaction, and also very young people were interacting and were showing very important, very interesting prize-winning artificial intelligence and data collection, but also devices, solutions, which I personally found extremely impressive. All of the conference was impressive, but I was most impressed by the young people showing their new inventions. The bad news is that some of them mentioned that they were my students 30 years ago, so I, on the spot, learned how old by now I am, because it is now the students of 30 years ago who are much better in the field and come up with wonderful ideas, and they will hopefully also make a fortune with these ideas. So this was a very moving moment when I saw former students now move forward and explain to the minister in simple language what they are trying to make possible for us in the future. So that was a very moving moment. Ultimately, I fully agree with Joe Lennox's idea. We need showcases, we need best practice, we need, let's say, an agenda, and we need to move forward from where we currently are. So in a nutshell, we need another meeting. And we will meet in September again at Harvard University. We will also meet here in Berlin again, because the Robert Koch Institute is coming up with a wonderful meeting on artificial intelligence and public health, because in the sphere of public health, where a lot of the benefit is to be gained, we, for example, know that there is very, let's say, strong risk factors for many diseases. But we know that small groups within the population of those carrying these risk factors, they do not get the disease. And with a large data collection, we will be able to solve this. We will be able to solve this enigma, as a matter of fact. And artificial intelligence will bring us there. So we will have another meeting in November, and I'm already inviting all of you for that meeting here in November, which we are going to have then. Ultimately, we will move forward with the legislative agenda not only here in Germany, but also with the development of the European Health Data Space. I personally think that the European Health Data Space will be very influential and very strong because it will connect European countries, and most European countries have fairly universal reimbursement systems. The problem currently is that the data which is collected typically is only data which is, let's say, valuable for reimbursement. But we could use the very same data collection methods in order to gain data which is meaningful for research or also for treatment. And if that is done, and this is exactly the vision of the European Health Data Space, then Europe will suddenly become a very big player, a very important player, because it is a unified market for this data in that sense. And if we can then exchange these data with the US, I think we will have a very strong transatlantic opportunity here to move forward. So to sum up, this was a very successful meeting, full of ideas, but the meeting would not even have been possible without the team in my ministry organizing the meeting. Typically, the minister, let's say, gets the credit for such a meeting, but most of the work and many of the ideas actually derive from the team. And we have a very strong team, which is led by Dr. Susanna Orzigowski. If you perhaps could please stand up for a moment. Nick Schneider, also part of the team, very importantly. And Arlene Kaufman and Gregor Temp also being part of the team. So without you, the meeting would not have been possible. I hope I will see many of you very soon again, either in Boston or here in Berlin again. We will continue with this format. I think the format worked very well. And I'm very much looking forward of making as much use of what we learned here in the next weeks to come. We have important laws to be finalized over the summertime. This is also why I cannot offer a last opportunity to be involved in a chat or so forth. I wish you a wonderful trip back home, but I have to rush out because we have another meeting in the Bundestag for which I'm late already. So therefore, don't be grumpy or don't be mad at me for not joining the last half an hour or so in personal talk. I would have enjoyed it more than you, but unfortunately I have to rush out. Thank you for having been contributors. Thank you for having been, all of you, part of the team, and have a good way back. And see you at the next occasion after a couple of steps, important steps forward. Thank you.
First and foremost,
thank you so much. Oh, thank you so much. Pleasure.
Thank you.
Thank you. See you, Alexa.
Thank you so much. We can just join you, Minister Lauterbach, on this. Thank you very much to this brilliant audience who helped us to ask the right questions, to our brilliant speakers. These were so exciting conversations. So thank you very, very much.
Thank you to everyone. In this moment of joy, let us just say we've also had a great time. So thank you for your support. Thank you to everyone who's joined in the workshops, in the bar camps, in the panel discussions, given us some tips in the break. We really appreciate it. But for now, there's so much more to research on, to develop, to help, because as we heard so many times throughout the conference, health is what this is all about, helping people to live healthier lives in the future.
Have more fruitful collaboration and now a safe trip home. Thank you so much.